as our eyes are focused on Glasgow today and our governors are seeing how to cut the fossil emission and the CO2 emission, we celebrate today the second global conference of World the World Pneumonia Day. For this, we have the public director of the public health generally in Spain, Pilar Aparicio, who will do a warm welcome from our country.
So much. Yes. Well, I would like to thank Dr. Katia Filloni, the coordinator of the campaign, the World Campaign of Awareness of Pneumonia, to invite the Ministry of Health to participate in this open ceremony. I'm a little sorry because I thought I need to speak in Spanish, but I will try just to say the importance that for our Ministry of Health has this event. As we know, the burden of disease that means the pneumonia today. And this is very important because not only affects to the general population, but also affects in a very important manner to the children and the youngest part of the population. It's for that this event, that is a world campaign, is so important for us. It's true that we need to improve the knowledge of the disease and the importance of the burden of disease of this problem that is in the objective of sustainable development objectives and that have many factors that are preventive if we act in a decided and coordinated manner in the world. We all know the importance of the contamination of the air related to the infectious diseases and all respiratory diseases. It's for that, and it's important that today that we celebrate this conference at the same time that is the COP26 at Glasgow, we stress the importance to do as much as possible to put in action all the measures possible to avoid or to improve the quality of the air that we breathe every moment. I think for us, for everybody, it's clear that the contamination is one of these main environment cause disease and premature deaths in the world. It's for that we all need to do actions to improve the air that we breathe every moment. We know the importance of this contamination in our country too. We understand that we need to improve a lot, especially in our big towns, the quality of the air. We know that this bad air that we breathe every time not only cause pneumonias, but also cause cancers and other diseases. It's for that it's very important for all the health professionals to know all the environmental factors that affect the health and affect our respiratory tract. For that reason, we are preparing, we think that we will have very, very soon a strategic plan for health and environment that we think is or could be the best tool we are going to have in all the country to fight against all the diseases and all the factors in the environment that cause diseases. I'm sure that this event is going to be an excellent opportunity to discuss the different aspects related with the prevention of pneumonia and contribute to decrease the mortality and the morbidity related with all these environmental factors. Thank you so much for this event. Thank you so much.
And I would like to introduce Dr. Torres. Anthony Torres is a doctor and a researcher, and thanks to him, we know more about the pneumonia because all the research he has done over the past few years is done within this disease. He's my friend and he's my mentor, and he will give you his vision about the pneumonia.
Thank you very much, Arturo. Welcome to everyone in this afternoon. Today we celebrate the Global Conference for the World Pneumonia Day with the title Air Pollution and Pneumonia. So, two things. Air pollution is a well-confirmed risk factor for respiratory lung infections in children and in adults. So it's an important issue that personally is very difficult to control. So it's something that we can decrease, is something that we can avoid, and one of the main factors can disappear. As regards pneumonia, pneumonia is still a disease, an infectious disease, a respiratory infectious disease with a very high incidence, both in children and in adults. It kills a lot of people every year, especially in patients hospitalized or admitted to the intensive care unit. In the intensive care unit, for example, the mortality is or can reach 30 to 35%. It is an unacceptable mortality, despite that we have all the antibiotics, new respiratory support. And I think that we have to keep investigating because we can do a lot. We can do it. So I encourage the organizations and the research authorities and educational authorities to put more money for the investigation of pneumonia as compared to other diseases. I just want to remember some words from the great Louis Pasteur. It will be the microorganism will have the last word. And this is true because look at these 2 years, what we have seen with COVID-19. COVID-19, the most severe manifestation is a viral pneumonia, so it's another type of pneumonia. You can remember all the terrible consequences of that pneumonia, both in human beings. It has been an economical disaster as well, and the cost of health resources has been very high as well. So we have to do all the efforts to prevent pneumonia and to cure better pneumonia that will allow more patients to survive. I am also talking on behalf of the medical director, Dr. Antoni Castells, that cannot be here. So welcome. And I want to thank Katia Zilloniz, who is the coordinator and the real driver of this conference. Thank you very much.
Thank you very much, Dr. Torres. Now we will speak and to do the opening of this Pneumonia Day to Dr. Anshu Banerjee from the World Health Organization. He's actually the director of the Maternal, Newborn, Child, and Adolescent Health and Aging Division, and he will give us a perspective of what is the World Pneumonia Day.
Very much, and I'd like to share my slides. So waiting for the slides to show up, and it's happening. Thank you very much for this conference, and it's a pleasure to join you all. Pleasure to join you all at the second global conference for World Pneumonia Day, and particularly focusing on the impact of air pollution on pneumonia, a very pertinent topic, I think, in view of the fact that the COP26 is about to finish. Sorry, I need to go to the next slide, and that went wrong. sorry, I'm not sure why the second slide is not showing up. And maybe I'll just...
¿No se escucha él si yo hablo?
Just do it like this. I hope this is big enough.
No, I'm not sure if you can put it on the viewer's presentation. Yeah.
Yes.
Exactly. Oh, yeah.
Yeah, I'm not sure, but okay, let's continue. So globally, pneumonia deaths have declined between 2000 and 2019 by 56%, but this relative decrease has been slower for Africa, for example, compared to other regions. So we have regional inequities here. Currently, the global post-neonatal mortality is 53% of under 5 mortality, but there are regional variations, with the African region being above the global average. Global deaths due to pneumonia for children under 5 has been 740,000, which is 14% of the total under 5 deaths. But when we look at the post-neonatal period, so from 1 to 59 months, this is 490,000, which is 22% of post-neonatal mortality. For children from 5 to 9 years, we also have an additional 35,000 deaths, which is 7% of total deaths in this age group of children 5 to 9. These numbers therefore highlight that we cannot ignore the unfinished agenda for child survival, including the post-neonatal period. Yet scientists, policymakers, and program managers in high-burden countries, as well as experts and implementing partners, say that there is a need to invest in strategies to address this burden in children under 5. And I hope that this conference will bring renewed effort to this agenda. And the previous speaker has also highlighted the importance of research. I'm going to go to the next slide, and I hope it works, but I'm not sure. There we are. So when we have already seen that there are regional variations, but when we look at which countries are on track to achieve the SDGs, we know that 53 countries are off track in meeting the SDG target for under 5 mortality of at least as low as 25 deaths per 1,000 live births by 2030. And this map shows where these countries are and the regional inequities that exist. There are also inequities in seeking care for pneumonia between the wealth quintiles, with a 20% gap between the richest and the poorest. And the highest mortality is actually in humanitarian settings, where we have up to 10 times higher deaths due to pneumonia compared to non-humanitarian settings. And further, there are also inequalities in access and coverage of interventions, such as for vaccinations, and which is a major part of the pneumonia control strategy. So what should the response look like? The epidemiology of the causes of pneumonia is also changing. We know that viral causes of pneumonia, especially RSV, are predominant, but bacteria are still an important cause of severe pneumonia overall, while influenza and atypical bacteria are more common in children over 5 years of age compared to younger children. The high mortality is associated with age, malnutrition, comorbidity, and environmental, social, and economic factors. And it will therefore be important to include a risk stratification approach into the programs that are based on contextual, environmental, social, and economic factors, alongside clinical risk factors in the case management, and develop preemptive strategies for at-risk children, as well as develop follow-up care protocols after discharge. We have seen that many children who are discharged from hospitals after treatment for pneumonia die within a month or within 2 months after discharge. Other areas of action should cover the development and incorporation of technologies to improve the diagnosis of pneumonia including point-of-care tests, laboratory and imaging investigations. We should conduct basic clinical research to improve the management of pneumonia, look at behavioral research to improve coverage of interventions, and longitudinal research also to identify the sequelae of pneumonia. So the focus of this conference is on air pollution, and this is very relevant in relation to the COP26, as I also just mentioned. In 2016, we had 600,000 children under 15 who died from acute lower respiratory infections, which were caused by polluted air. Together, household air pollution from cooking and ambient or outside air pollution cause more than 50% of acute lower respiratory infections in children under 5 in low and middle income countries. People living in low and middle income countries are also typically more vulnerable to air pollution due to the higher levels of air pollution they're exposed to each day and the prevalence rates of diseases that are negatively affected by air pollution exposure, such as asthma or pneumonia. Indeed, while 52% of children in high-income countries are exposed to unsafe level of air pollution, in low middle-income countries, this percentage is as high as 98%. Populations living in slums or in nearby busy highways or roads, populations lacking access to clean cooking, or those that are in certain occupation are other examples of populations more vulnerable to the adverse impact of air pollution. And poverty plays a major role, and women and children are the most exposed. So finally, the way forward will be for us, first of all, to focus on high burden countries and vulnerable populations within countries and vulnerable populations within countries, and identify those high-risk children, households, and communities. Secondly, to build on primary healthcare revitalization, to prioritize and enhance investments nationally and subnationally. And finally, to build on global initiatives, such as identifying zero-dose children, looking at the WASH Alliance, scaling up nutrition, accelerated action for pneumonia, and also involving financing initiatives such as the GFF, Gavi, and the Global Fund for HIV-TB or AIDS-TB and malaria, and who can all support an expanded agenda for child survival. Thank you very much.
Thank you, Dr. Banerjee, for your introduction and for giving this world perspective on the themes that we're talking today, that is the air pollution and pneumonia. Now we will start all the presentations that we have today and we have scheduled today. And we will start with the presentation of what is the pneumonia awareness campaign. And for that, we have Katia Sillones, which is the organizer and the European leading of this global conference. Thank you, Katia.
Thank you, Dr. Huerta, for the introduction. So thank you to everyone who is joining us today in this global conference. It's a pleasure for me to summarize the worldwide pneumonia awareness campaign, PneumoLive. So last year, we initiated this worldwide pneumonia campaign with the idea to give visibility to pneumonia and to raising awareness about this infection disease. This campaign is not-profit and collaborative campaign, and is member of Every Breath Counts Coalition and has the support of 25 organizations and scientific societies globally. Last year, in the World Pneumonia Day 2020, we decided to mark the World Pneumonia Day, illuminate iconic buildings around the world. So we achieved to illuminate 252 monuments around the world across 52 countries. Why we did that? Because we think if there is a World Day, it's because there is a world problem. And pneumonia is a huge problem. As you can see in this graphic taken from the Missing Piece report, based in the Global Burden of Disease report, in 2019, more than 2 million of people died a cause of pneumonia. As you can see, pneumonia killed more people than diarrhea, than tuberculosis, and than HIV together. And this is without taking account the deaths relating to COVID-19. So sadly, this pandemic shows the dangers of pneumonia and also shows us that no government has a specific strategy to control this preventable infection disease. So pneumonia receives less research funding than other infection disease, despite that it's the leading infection cause of death, as you can see in this graphic. Last year, we also held the Global Conference for World Pneumonia Day. The idea of this conference was to invite the main experts on pneumonia and the representative of the main organizations that fight against pneumonia to show us what is the picture of pneumonia in the world, what is the problem, and how we can solve it. So interestingly, last year also, this article was published in Lancet. The majority of the authors were speakers in our conference, and they give 6 points of strategies to end pneumonia deaths that I want to share with you. The first one is develop and implement pneumonia control strategies. The second one is prioritize vulnerable populations. The third point is finance pneumonia control and treatment adequately. The fourth point is accelerate breakthroughs innovations. The fifth point is track progress with transparency, accountability, and inclusiveness. And the last point is stronger partnership. And for me, it's important, this point, implication of national governments for the health of their citizens is really important. So turning on this year, this World Pneumonia Day 2020, we decided to give more information about pneumonia. This was the reason that we created some educational material, 2 educational videos, and 6 infographics in 7 languages. Our idea was to give information in a simple way to the people, and we asked to our friends, to our colleagues that support the campaign, that share this material in social media like Twitter, Instagram, Facebook, and YouTube. So you can see here, this is an example of the video that we share so the people can understand what is the problem of pneumonia and the consequence, the main points, the risk factors, the prevention. And these are some examples of the infographics in different languages. And of course, if we share information with the people, this information needs to be validated. This was the reason that we created, as a part of our campaign, Pneumo Strategy. Pneumo Strategy is a group of experts in respiratory medicine, infectious disease, primary care, and critical care that help us to validate all the information that we share with the people. So you can see here the members of the Pneumo Strategy group. And because we want to give more visibility to all the material that we create, we also create a face mask, as you can see in the pictures, and we ask to the colleagues to share the picture wearing the mask, and together with the link of our material, so we can reach more people with more information. There are some examples of the Twitters that our friends shared. This year, we also held the second global conference for World Pneumonia Day, and will be focused on air pollution and pneumonia, the invisible killer. So as you can see in this imaging, air pollution, child wasting, and smoking are the leading risk factor-related pneumonia deaths across all ages. And you can see that indoor pollution and outdoor pollution are the big risk factors. And despite that there are a lot of scientific information that demonstrate the dangerous relation between air pollution and our health, and especially pneumonia, we think we need to do more. So this was the reason that we invite a panel of 12 experts in air pollution and pneumonia to share with us their experience about this problem and how we can solve it. So I want to thank you to all the speakers for donating their time and their experience with us. Also, I want to thank to all the scientific societies and organizations that support our campaign. And finally, I want to thank to all the sponsors that support this campaign this year. Thank you to everyone.
Thank you very much, Katia. I think it's a very huge effort for you to do the organization of such an event of this importance and that is globally needed. So we will start with the other presentations. We will now go to Dr. Patrick Race. Dr. Patrick Race is the Director of the Centers of Disease Control and Prevention of the Agency of Toxic Substances and Disease Registry, who will speak to us today, and he will present the impact of air pollution, of pneumonia, and the global health. Dr. Patrick Race.
Yes, good day, everybody. Welcome. As you heard, I'm the Director of the Center for Disease Control's National Center for Environmental Health in the United States. And I'm going to share with you a perspective from the Environmental Health Center on air pollution work that we're doing and touch on how that relates to pneumonia risk rather, and steps we can take to reduce exposure and therefore reduce risk going forward. Next slide, please. So just a little background about the National Center for Environmental Health. We work to protect people's health from environmental hazards that can be present in the air we breathe, water we drink, the world that sustains us. We do this through a number of mechanisms, including partnering with local, state, and territorial health departments, tribal nations, and organizations, as well as international groups. We monitor and investigate environmental public health hazards, in this case, air quality. We respond effectively to emergencies and weather events. An example here would be wildfires as an emergency event that would have air pollution impact that could drive pneumonia risk. And of course, we want to work to improve guidance, education, and implementation of best practices across the country. So I'll touch on all of these aspects of the work we do in the air pollution arena and how that might impact pneumonia risk. Next slide. So I'm going to mention just a few things in the limited time we have this morning. I'm going to talk about some of our air pollution activities. I'll focus on some ambient and indoor air quality work we've done on clean cook stoves in particular. We'll talk more specifically about wildfires. And lastly, I'll say a few words about biological monitoring that we conduct here at the Centers for Disease Control and Prevention in Atlanta. Next slide, please. So I just want to share this map about the distribution of pollution. And if you remember the map that Dr. Banerjee provided a few minutes ago, you'll see there's a lot of overlap between the burden of disease and the burden of air pollution. And that's probably not a coincidence. But what's important is, similar to the comments made about the burden of disease, this indicates there's a big pollution disproportionate impacts on poor and vulnerable populations across the country. So that as the burden of disease is highest in low and middle income countries, so the burden of pollution is highest in these countries as well. So you can't address one without addressing the other. So in 2015, for example, the greatest number of deaths due to pollution occurred in Southeast Asia, with over 3.2 million deaths occurring in the Western Pacific as well. So this is an important health equity issue, and the current Biden administration and the CDC administration has taken on addressing health equity as an important priority, both in the US and globally. And so it's important to consider now factors like air pollution as a part of our global security strategy, global health strategy across the globe. So while we're interested in, obviously, air quality in the United States, it's also important to consider globally as well. Next slide. So I'm just going to give a few statistics here just to help place things in perspective, similar to some data you see from other people. So in 2016, ambient household air pollution caused over 500,000 deaths in children under 5 years of age, and over 50,000 deaths in children between 5 and 15. 91% of the world's population live in places where the air pollution exceeds WHO guidelines. There's 7 million deaths each year from exposure to ambient and household air pollution, and over 1.4 million of these premature deaths are due to pneumonia. So this just helps place the problem in perspective. So air quality and pneumonia risk are inextricably linked. Next slide. So also just emphasizing, as other people have mentioned, there are certain populations who are at more risk from exposure to air pollution. These include people who work outdoors, and our colleagues at the National Institute for Occupational Safety and Health, part of CDC, are interested in the workplace and particularly outdoor workers. We know that children, as we've heard, are especially vulnerable population because they have increased exposure. They breathe air more air relative to their body weight. They're still growing and developing. They also have less nasal deposition of particles, meaning the higher proportion of the particles that they inhale can penetrate deeper into the lungs. All these, among other factors, put them at increased risk. Women working in smoky kitchens, as we've heard, are exposed to high levels of air pollution, and older adults are a particular population at risk as well. So these are all groups that we have to focus on. Next slide. So as an air pollution scientist myself and an exposure scientist myself, I like to use this slide to help orient people to what we're talking about. And I find this slide is just very informative in terms of what it means to be exposed to particulate matter air pollution in this case, recognizing that there's more pneumonia risk associated with air pollution, pneumonia risk than just particulate matter. Ozone and nitrogen dioxide, for example, are also important irritant gases that contribute to pneumonia risk. So if you look at the panel on the left-hand side, this is a Baltimore, Maryland, the city where I worked for many years, on a typical clear day where the particle air pollution is 12 micrograms per cubic meter. Pretty clear day, pretty typical low risk air quality day in Baltimore, Maryland. On a bad day in Baltimore in the middle of the summer, when the air pollution is high, it can reach almost 100 micrograms per cubic meter. You can see how the haze on the horizon has obscured the view that you can see, particularly if on the first panel you can see a bridge in the distance. In the second panel, you can't tell there's a bridge there. Now, the third panel shows you what happens when there's pollution from wildfire in communities that are many kilometers away from the wildfire. And we can see we can have pollution well over 100 into 200 in the high hundreds of micrograms per cubic meter. And so this indicates why air quality during wildfire events are important, not just close to the event, but many thousands of kilometers away in many cases. And then the fourth panel is a historical panel, the London smog event of 1952, where that's been historically documented repeatedly. It killed thousands of people over a 4 to 5 day period in 1952. And you can see the estimates of particle air pollution were between 1,000 and 2,000 micrograms per cubic meter. And that's a picture of people walking during the day during the London smog event in 1952. And lastly is a picture I took in an indoor environment in Peru during a cooking event. And I was actually having dinner in this house during this event. And you can see the particle air pollution is between 10,000 and 15,000 micrograms per cubic meter. So this is the spectrum of exposures that we have to deal with across the globe in terms of air quality. We have clean air days, we have bad ambient air pollution, we have bad ambient air pollution because of specific events like wildfires. And of course, we can't ignore, as other people have mentioned, and we'll hear more about indoor air pollution and cook stoves later today, but that's an important consideration as well in terms of the spectrum that's way off the scale in terms of the pollution impacts that we might expect. So I like this slide because it reminds people when we're talking about air quality, this is the range of things we're talking about, covering orders of magnitude, many orders of magnitude of particulate air pollution in this case. Next slide. So I indicated on one of my earlier slides that one of the things that we do at CDC is we advance the science. In this case, the science of air quality and pneumonia. And here's a paper we published last year on both that indicated that both particulate matter and ozone were associated with increased hospitalization rates due to pneumonia. And we looked at these data and we looked across all age groups, which was one of the unique contributions of this paper. And so, for example, if we look across all age groups, we saw a 4% increase in ED visits for pneumonia for each 20 ppb increase in ozone concentration. While we often talk about, in terms of ambient air pollution and indoor air pollution, particulate matter, we can't forget that there are other components of air pollution that drive the risk as well. And I illustrate this with the ozone contribution in this paper in particular. Ozone is also important because it's one of the air pollutants that we predict, or the predictions suggest will increase with climate change over time. As the temperature gets hotter, the photochemical production of ozone will increase in communities around the world. And so we expect that this to drive the risk even further as temperature rises increase globally. So again, the increased risk is across all age groups, and this is based on a longitudinal study of people 65 years in age and less looking at ED visits. So these are emergency department visits for pneumonia across the United States. Next slide. So I'm going to touch just now a little bit more specifically on some of the work that we're doing on cook stoves and air pollution, and I'll mention something about wildfires as well. Next slide, please. So as we've heard, over 3 billion people cook with solid fuels and open fires across the globe. There's 3.8 million premature deaths from illnesses attributed to household air pollution. And it's not surprising if you think back to that slide I showed you about the particulate matter concentrations in indoor environments during these cooking events. And we know that 27% of these deaths come from pneumonia in particular. So it's important to focus on, if we want to deal with air quality and pneumonia, we can't ignore the problem of indoor air pollution and biomass burning and biomass cooking. Next slide. So one of our goals at CDC is to help communicate and do research and build a portfolio of activities that will address the cook stove problem. We want to build an evidence base on clean cooking. We want to understand what the health impacts are. We want to work to improve access and consumer demand for LPG gas by addressing key market barriers, such as financial constraints and consumer attitudes, and dealing with the availability issues. We want to evaluate the implementation of these efforts in a systematic way to make sure that we understand what the benefits are going forward. We work closely with a number of partners. One of the other things I mentioned in when I first talked was our strategies is to partner with people. In this case, we partner on a global scale. We work closely with the Global Alliance for Clean Cook Stoves, the Bloomberg Foundation, and a number of groups within certain countries, with different countries around the world as well. We work to monitor and evaluate household air pollution and cleaner cook stove technologies. As I said, we want to build the evidence base, improve consumer demand, and implement the effectiveness of any clean cook stove strategies that might be implemented. Next slide. More specifically, we have work that we're doing in India, Kenya, across Central America to better characterize and understand the impact of cook stoves. Prior work addressed the barriers to stove and clean cooking programs as well, trying to implement the scalability of LPG programs in different countries like India and Guatemala. More specifically, in Guatemala, we work with partners to evaluate the use of LPG gas in stoves in communities where women entrepreneurs are being employed to market and sell stoves, as well as other important health information about the health impacts. For many women, this is their first job and empowers them to earn income, improve the standard of living, and devote some of their time to the education of their community members. In India and Cameroon, we're currently engaged with preliminary work on projects designed to evaluate the health effects of altered cooking stoves. In Kenya, we evaluate 6 different improved cook stoves to reduce exposure to air pollutants and gather information about their preferences and use. We found, as other people have found, that the traditional wood-burning three-stone fire produces unacceptably high air pollution levels. And while the different clean cook stoves did improve the air pollution, they weren't sufficient to really think to improve the health effects at the end of the day. So we really feel the science has told us now that if we want to move to a cleaner fuel, we have to talk about LPG bottled gas, not alternate stove technologies in particular. So we're looking forward to participating alongside other federal and international partners in these activities. We're actually closely with a number of important trials on clean cooking technologies, and we're looking forward to the information that comes out of that and how we can work to implement that internationally. Next slide, please. So I want to say a few words about wildfires. I don't need to remind you that wildfires are on the rise across the globe, not just the United States. And here you see that indicated on this slide. They're rising globally. There's many impacts from wildfires across the country. It's in the news all the time. The smoke pollution is an important driver of health risk, particularly pneumonia. And we know that there's, for example, this last year, 7.4 children in the United States, 7.4 million children in the United States were affected by wildfire smoke, many of them in the Southeast and Pacific Northwest of California. So next slide. One of the challenges of wildfires is that while the pollution can be most intense close to the wildfire, the pollution can actually spread for many thousands of kilometers away from where the wildfires are. And here's a satellite image from a study that I participated in a number of years ago, where the red dots are up in Quebec, Canada, and there was a series of wildfires up in Quebec, Canada. You can see the brown haze of the smoke plume down across the whole eastern United States. And so in Maryland, where I was at the time, you see the black dot, we saw significant increases in air quality, in air pollution during those events, and we contribute directly to the wildfires. In Canada, thousands of kilometers away. And we're able to look at the ED visits across the eastern seaboard, and we saw a very clear increase during this 4-day period when the wind was just right and the atmospheric conditions were just right across the eastern seaboard of the United States for increased hospitalizations and ED visits for a number of health effects, including pneumonia across the East Coast. So this is a global problem, and it's a transboundary problem, and it's an important issue to think about in terms of climate change. And while there certainly is an emergency response function for people that are very close to the wildfires, there's also an important global exposure issue as these smoke plumes spread thousands of miles away. Next slide. So as part of our work with CDC, we develop a number of outreach materials and education materials. You'll see here an example of a wildfire smoke pamphlet we produced. These outreach materials are designed to provide information and resources to address the public health impacts. We work with EPA on a number of these things. The U.S. Environmental Protection Agency developed these guidelines. We have the Wildfire Smoke Guide for public health officials, so we're targeting public health departments here. We have a strategy for public health to reduce exposure that's designed for the public. And we have Wildfire Smoke and Health communication materials designed for doctors, nurses, and health professionals as well going forward. We provide technical assistance, and we have trained advisors across the United States about air pollution and wildfires. We participate in a number of National Academies of Sciences in the United States committees, including looking at the chemistry of wildfires. There's a lot of concern that the composition of a wildfire smoke is different from the typical ambient air quality, and the concern is that that composition might be driving a differential health risk. We're also looking at syndromic surveillance data, health data across the United States, so we can better track the health impacts of the wildfire events as they're occurring, so we can get the health resources and the risk communication and the health department resources to places where the health effects are occurring as they're occurring. That's a big challenge to get real-time data to look at the health effects as they're occurring. Next slide. So this is an example of some of the guidance we provide. We're very interested in teaching people how to minimize their exposure. If we can minimize their exposure, we'll minimize the health risks for a whole host of health impacts, including pneumonia. So we tell people to choose a room in their house that they can close off from outside air. We know that oftentimes during wildfires, the penetration of ambient air quality in the indoor air environment makes the indoor environment unhealthy as well as outdoor environment. We talk to people about setting up portable air cleaners or filters. We educate them about wearing respirators and masks to reduce their exposure when they're outside, and even sometimes when they're inside. We make sure that the doctors and the clinical communities are well educated about the health effects. And we develop these resources about also to protect pets, which is a big concern to people. And we make sure these resources are available broadly across the country. Next slide. Lastly, I'll just say that we have a division of laboratory sciences that's world-renowned experts in biological monitoring. There's a number of biological monitoring opportunities there for looking at air pollution exposure, whether it's wildfires or ambient air quality, including PAHs and a lot of VOCs. In addition, while tobacco smoke is not considered air pollution particularly, we do know that secondhand smoke exposure is a driver of health risk also. And we have a very aggressive program on secondhand smoke exposure measurement and reduction across the US. And these data on measuring secondhand smoke exposure provide benchmarks for health control across the United States as part of our national health and nutrition examination survey. So just to wrap up, I just want to say that the environmental health community has an important role to play in reducing health risks for respiratory infections. We have to focus on the sources of air pollution that are driving that risk and work to minimize those exposures through national policy levels, through state and local efforts, and through educating people about what their exposure risks are and how to reduce those risks. We want to assist in educating people about those risks. We want to support local governments. We want to develop guidance and policy evidence to drive policy, and we want to be prepared to respond to emergencies when they occur. These are all activities that we take on through the Center for Environmental Health at CDC. Thank you very much.
Thanks for your very nice presentation that give us all the global panorama of what we have today on global health. And now we have the next presentation in line is the presentation of Lead Greenslade. Lead is one of the responsibles, along with Katia, to organize this kind of conferences around the world. Lead Greenslade, the coordinator of the Every Breath Counts coalition, and she will speak to us how is it possible to organize all these coalitions? How is it possible to get together all the governments and the scientific societies to join together in a conference like this? Hi, Lead.
Hi, great to see everyone again this year. So first of all, a big thank you to the Hospital Clinic of Barcelona for hosting us again this year. And of course, a special thank you to Dr. Katja Sionese, who has organised yet again another Global World Pneumonia Day conference, which is fast becoming, I think, the flagship conference of World Pneumonia Day. So I've been involved in World Pneumonia Day from the very beginning, which began in a basement room at New York University in New York City in 2009. And this is the first time in 13 years the theme is air pollution. So it's well past due that we talk about this. I've been asked to speak about the need for more alliances between the respiratory health community and clean air communities. The imperative for partnership is completely clear. The climate crisis is a health crisis. It's the burning of fossil fuels that contributes most to air pollution-related deaths, almost 7 million in 2019, and that's according to the Global Burden of Disease. This is pre-COVID. We still don't fully understand what the pandemic has done to air pollution-related deaths, but I'm sure Chris Murray, when he speaks later, will cover that. Now, we know the vast majority of these air pollution-related deaths are actually from non-communicable diseases, so cardiovascular diseases, chronic respiratory conditions, cancers, diabetes. And communicable diseases are a smaller burden, but today that's where I'm focusing my comments on air pollution-related pneumonia deaths, and specifically the need for more partnership. So I'm going to run quickly through some of the data we're already sharing. Once again, all the data we use is Global Burden of Disease, the latest from 2019. You can see there very clearly air pollution as the leading risk factor for death from pneumonia. That's across all ages. And it's the second leading risk factor for child pneumonia death after malnutrition. So children are specifically vulnerable to air pollution. Household air pollution contributes more to pneumonia deaths than outdoor, but not by much. You can see the big circle is pneumonia deaths across all ages, and the smaller circle is of that larger pie, what proportion is children under 5. And you can see there the enormous impact of household air pollution on children under 5. Pneumonia, unlike many other infectious diseases, targets the very young and the very old. If you look at pneumonia deaths across the life course, it's a U-shaped curve. Unlike malaria, unlike TB, unlike HIV, unlike many of them. And that's because it targets the children and the elderly. 75% of air pollution-related pneumonia deaths are among the very young and the very old, which tells us where we need to be targeting our support for maximum impact on lives saved. This is a very interesting picture. Air pollution-related deaths, pneumonia deaths among children are falling. We've put a lot of energy into that in the last few decades, but look at what's happening amongst adults. It's rising. Now that speaks as well to the aging of populations. It also speaks to the increasing role of outdoor air pollution, which disproportionately impacts adults. If we don't intervene to stop that black curve, it will continue to rise. So what are we doing about it? Every Breath Counts Coalition is a coalition of health organisations. We have more than 50 now. And we began in 2017, focusing on pneumonia deaths. So we come from the health sector, infectious disease researchers, advocates, companies. We have a very, very broad representation. And we came late to the party to air pollution like many health organisations. We weren't paying attention, frankly, to the data. And so it's only recently that we've really been focusing on air pollution and pneumonia. And we've done that by creating a working group within the coalition, which is co-chaired by two of the leading air pollution individuals, Sumi Mehta and Sandra Cavalieri, but also the organisations they represent. Sumi from Vital Strategies, many of you may know the work they do in air pollution and health, and Sandra from the Climate and Clean Air Coalition. This is how we as a coalition are trying to build alliances between the health people and the climate change and clean air people. And one of the first things we've collaborated on is a scorecard, and we just launched it today at COP26 before we came to this event. And it's a scorecard, it's available at that link, that ranks the countries with the largest numbers of air pollution-related pneumonia deaths. This is our effort to get the attention of health ministers, particularly in the countries affected, so they have their eyes on air pollution. Typically, it will be the environment minister or the energy minister, the industry minister, the agriculture minister. They're all very focused and involved in air pollution, and the health ministry has to really build connections there to be able to tackle this issue effectively. What did we find when we did our scorecard? We found that 70% of air pollution-related pneumonia deaths are in these 20 countries. 13 of them are in Africa, sub-Saharan Africa, and 7 are in Asia. Once again, this tells us as health advocates and activists where we need to focus interventions and join forces with our air pollution colleagues to really drive down air pollution so we see the reduction coming through in pneumonia deaths. If we're not working on air pollution in these countries, we are never going to solve our health challenges. And that's our message with the scorecard. Of deep concern to us was this finding. These 17 African countries, more than 50% of their pneumonia deaths are driven by air pollution. Now, a lot of that is about household indoor cooking, and a lot of that burden falls on children. So we're super concerned about this collection of countries, many of them in West Africa, and we really need to get together with our clean air pollution, climate change colleagues if we're ever going to bring down pneumonia deaths, particularly among children in this set of countries. 80% of household air pollution-related pneumonia deaths are in 20 countries. Once again, it tells us where we need to be focused on different solutions to indoor cooking. We're very excited by some of the research that's coming online. The HAPPEN trial just announced actually today at COP26 some early findings from their randomized control trial in 4 countries. They have a breakthrough. They have found a way using LPG stoves and a lot of support to pregnant women and their families to bring indoor air pollution down to the levels required by the WHO across the 4 settings, and they did it quickly. So we are confident that we're making gains there where we could start to target some of these household air pollution related deaths. This is going to be a tough mountain to climb because most households in these 20 countries that we're focusing on in the scorecard are using polluting fuels for cooking. So we have so far to go with the indoor air pollution agenda, but it's certainly no better when it comes to outdoor. Once again, in the 20 countries with most of the air pollution related pneumonia deaths, outdoor air pollution is shockingly high and getting worse. So we have our work cut out for us. To come to the point again, the original question of who needs to join forces to reduce air pollution, we need to surround the problem with at least these 6 sectors. Health is just one. We have industry there. We know a lot of the polluters, particularly the outdoor air polluters, is coming from industry and agriculture as well, agricultural waste. The energy sector is critical, particularly to solve the indoor air pollution problem. The environment ministry, urban development, because crowding in the cities is driving a lot of the air pollution and pneumonia burden. So we need structures that bring all these groups together regularly at the national, regional and global level, and we don't currently have them. We're trying to make an effort with our coalition, but so much more needs to be done. And I'm hopeful out of COP26, we've had a number of new initiatives announced at COP26. We just do a much better job of getting together, designing policies together, investing together, delivering programs together, and really holding ourselves accountable for the same outcomes. The health people should be measuring air pollution as if it's one of their own goals, and the air pollution people need to be measuring health gains. We need to be much better integrated with the way we measure our performance. So the key for me is integrated goals. Integrated targets and data must be the driving force to bring these coalitions together. It's one of the reasons we love the global burden of disease, because it enables you to see not just the cause of death by age group, by country over time, but the risk factor analysis, which is where the air pollution comes in, is extremely valuable. So we think with more data that put these factors together would help us be more united in our approaches. We have called today on action in the scorecard. We've called on the governments where most of the air pollution-related pneumonia deaths are to make some big changes. And the first change is we would love them to introduce a new goal of reducing by 50% air pollution-related pneumonia deaths by 2030. This would force the air pollution people and the pneumonia people to come together to achieve that goal. Some ways that we might do that, because that's very ambitious, we clearly have to increase access to clean cooking fuels and technologies. Huge agenda. We also need to work simultaneously on reducing outdoor air pollution, and COP26 had very much to say about that, and we have a new set of WHO air quality targets to guide us. Countries need to adopt those and work towards them. Number 3, I would love to see every government in our scorecard introduce a clean air task force, ASAP, and bring us all together at the national level, and then have the global health actors mirror that and come in behind those national clean air task forces to support them. And of course, number 4, we have to publish progress. Nations have to publish progress, not just the global actors, but countries have to publish regularly their performance to these targets in a way that we can all track and intervene to support if necessary. Of course, not every burden is the same in every country. So we encourage the countries to use the global burden of disease to work out where their burden falls. Is it primarily amongst children from indoor? If it is, that's where your priority is. Or in other countries, it's going to be primarily amongst older adults and outdoor. So they need to calibrate their national strategies according to where the air pollution disease burden falls. And finally, this is how our scorecard looks. If you click on, if you go to the link at the top there, it's a very easy to read 3-page document. You can see our call to action on page 2. That's a summary of what I just shared with you. The scorecard itself is the last one. And that's the 40 countries ranked in order of bad, I'm afraid, to less bad in terms of the number of air pollution-related pneumonia deaths every year. So we would love for you to share that, particularly at the country level, and encourage the health community and the air pollution community to take a look at it. We would love both communities to throw their weight behind it. It is a co-creation, our first co-creation of a piece of advocacy like this from the air pollution and health community, and we hope it's the first of many. Before I close, I want to end by putting on a wonderful mask. I hope you can see it. Courtesy Dr. Katya Sioni. She has many more of these. We're masked up for World Pneumonia Day. We're masked up for COVID. We may be masked up for a long time coming, but we're doing it in style with our World Pneumonia Day mask. So thank you very much.
Thank you very much, Lid, for all your energy, for all your effort, and for bringing us together and sit today here again on this global conference. So the next presentation will be on Dr. Catherine Tone. She's an associate research professor on the Barcelona Institute of Global Research, and she will speak to us about the air pollution and the non-communicable diseases. Catherine, your turn.
Yes, thank you. So should I share my slides directly?
Yes, please.
Okay.
I think we can see you, but we can see your slides.
Okay. Let's give me 1 second here. And how about?
Okay, beautiful. Thank you.
Yes, okay, success. So thank you so much for the invitation to present as part of this very important event. It's a pleasure to be here. I was asked to give an overview of the role of air pollution in non-communicable diseases, which I must say is not such an easy task, because it's a very broad topic with a very large and diverse evidence base. But I have pulled out a few points that I wanted to highlight with you today. And those key points are that air pollution is associated with a very broad range of non-communicable diseases. Air pollution influences NCD risk in every life stage. And I'll say a little bit about the role of air pollution in the relationship between urbanization and NCDs, as well as the potential role of air pollution in the interplay between communicable diseases and non-communicable diseases. So there is now a large body of evidence linking air pollution exposure over different time windows, spanning from a day to several years, to adverse health impacts in essentially every organ system in the human body. Early studies primarily focused on the impacts in the lungs as one of the first points of contact with air pollution. But in the past few decades, the epidemiology has really expanded to include a very wide range of outcomes, including cardiovascular disease, metabolic outcomes, adverse birth outcomes, as well as neurodevelopment, neurodegeneration, cognitive performance, and more recently, mental health. It seems that whatever health outcome we select, there is a good chance that it is related to air pollution from either outdoor sources like traffic, power generation, or indoor sources, for example, from cooking and heating with inefficient and highly polluting fuels and technologies. So you may be wondering, how is this possible? This seems, at first glance, quite hard to believe. But I think it makes much more sense when we consider the very general mechanisms by which air pollution is understood to influence health. We have evidence now of ambient air pollution linked to each of the processes listed in this figure, which are these essential cellular functions, such as oxidative stress and inflammation, epigenetic alterations, alterations in the nervous system function. And I believe we would have a similar understanding of the relationship with household air pollution if we had more evidence. But it's through these very common mechanistic pathways that air pollution is able to manifest as a very diverse set of non-communicable diseases. We now have evidence that air pollution affects NCD risk at every life stage, starting from the very beginning of life. Exposure during the in utero period affects not just birth outcomes like low birth weight, but also NCD risk in later life. This is in addition to the contribution of exposures that one experiences in later life. So I think it's important when thinking about the contribution of air pollution to NCD risk to really appreciate that it's impacting NCD risk across the life course, and conversely, reducing levels of air pollution can deliver very large cumulative health benefits across the life course. So to give you a more specific example, I've included this slide here, which is based on a recent systematic review and meta-analysis of the association between air pollution and blood pressure in children and adolescents. So in this first panel, we have the pooled associations from the meta-analysis for systolic blood pressure. In the bottom panel, it's for diastolic blood pressure. And in the first row, for example, we see the associations from this pooled analysis from short-term studies. So these are studies looking at exposure to air pollution in the day or a few days before the blood pressure measurements, where we see a positive association for PM10 and systolic blood pressure. For longer-term exposures, the impacts on health are quite a bit larger than for these shorter-term exposures. And you can see PM 2.5 has the strongest association with systolic blood pressure in this meta-analysis, and quite similar results for diastolic blood pressure. So of the studies that were included in this meta-analysis, most of them focused on exposure during the postnatal period, but we have increasing evidence from many birth cohort studies, for example, that the prenatal period, exposures in the prenatal period are also associated with blood pressure in childhood. And this evidence is relevant because we know childhood blood pressure is a predictor of blood pressure later on in adulthood, elevated blood pressure in adulthood is a very important risk factor for many non-communicable diseases. So we have a very large literature linking ambient air pollution exposure in adulthood to health outcomes such as hypertension, as well as cardiovascular events like stroke and myocardial infarction. I've included this slide here, which is well, I'd like to say we now have evidence from several studies that these effects are observable at very low levels of air pollution. I've included this slide here, which is from a recently published study based on several European cohorts, where they looked at the effect of long-term ambient air pollution on incident stroke and coronary heart disease. I know Barbara Hoffman, was one of the speakers for this afternoon, was involved in this study. And what they have reported here are positive associations between several pollutants, particularly for incident stroke. And what I think is a really important point that this paper shows is the exposure range that's included in these European cohorts. So this study includes several cohorts with quite low levels of ambient air pollution. These are populations in Northern Europe. And most importantly, all of these cohorts had exposures that were well below the European health-based standards that we have currently. So this is one of many studies that were conducted at relatively low levels of exposure, and essentially there's no evidence of a threshold below which there are not detectable adverse effects of air pollution. So this is an important part of why we see very large attributable burdens of disease to ambient air pollution, because essentially everyone is exposed to levels of air pollution that can damage health. So the availability of epidemiological evidence at higher concentrations found in world regions outside of Europe and North America has increased considerably in the past few years, and this is really a big step forward. This is an example of a study from a high exposure setting, so Delhi, India, where the annual average PM 2.5 is 92 micrograms per meter cubed, compared to around 12 micrograms per meter cubed that I just showed in the slide previously. And in this paper, the authors reported positive associations between PM 2.5 and blood pressure for PM levels in the day, the week, the month, as well as the year prior to the blood pressure measurement. And we very much need more of these air pollution epidemiology studies in low and middle income countries, particularly since the vast majority of deaths from NCDs occur in low and middle income countries. One of the sort of upstream driving forces that has been highlighted by the WHO and others for the high burden of NCDs in low and middle income countries is uncontrolled urbanization, which typically leads to increased levels of ambient air pollution as well, although it can also lead to a parallel decrease in household air pollution as you have increasing access to clean household energy. However, we have very little direct evidence on air pollution exposures and the role of air pollution on health in rapidly urbanizing contexts. This slide shows one paper where we tried to investigate this. We looked at land use change over about a 15-year period in a rapidly urbanizing area of South India and the influence on several cardiometabolic risk factors. Specifically, we grouped participants in this cohort into 3 exposure groups: those who had essentially no change in the built up land use around their homes, those that had a relatively slow increase, and those that experienced a fast increase in built up land use around their home. And we linked this to several health outcomes. And what this figure shows here is that if we take the group that experienced fast increase in built up land use compared to the group with no change, we see about 1.5% higher systolic blood pressure, 2.4% higher diastolic blood pressure, and about 2.2% higher waist circumference. So we then went on to investigate whether some of these observed associations could be explained by ambient air pollution. So we conducted an analysis to investigate that and found that, yes, indeed, there is a small but detectable part of these associations that can be explained by ambient air pollution exposure. It's often assumed that urban environments are worse in some way for NCD risks. And I included this figure to highlight that it's not necessarily so straightforward. This figure is from a large systematic review and meta-analysis of urban-rural differences in hypertension prevalence in low and middle income countries. And we found that there is an increase, or there is a higher level of urban compared to rural prevalence in hypertension in some contexts, particularly in places that are starting to urbanize but are quite early on in the urbanization process. And you can see in this figure that this is where we find most of low-income countries falling. Whereas with increasing urbanization and also with increasing economic development, as we showed in some other analyses in this paper, which aren't presented here, essentially the urban-rural prevalence converges. And I think this is very, very interesting and sort of gives us presents some interesting questions of the potential role for air pollution, ambient air pollution, as well as decreasing household air pollution in explaining some of these patterns. But this is an area for future research, I think. So finally, I would like to comment a bit on COVID-19, which I think has been a really useful reminder of the overlap between communicable diseases and non-communicable diseases, which I think increasingly is becoming a bit blurred. We know many communicable diseases result in subsequent non-communicable diseases, and we see clearly from the experience with COVID-19 that pre-existing non-communicable diseases was an important predictor of severity of COVID outcomes. During the COVID-19 pandemic, there's been a lot of interest in the potential role of air pollution on COVID severity. What I've presented here in this figure are some results from a cohort study that we conducted in Catalonia, Spain. This is a cohort where we had conducted serological testing for SARS-CoV-2 infection in a quite large proportion of cohort participants. And what we found in this study is that long-term exposure to air pollution was not associated with SARS-CoV-2 infection, but it was associated with severity of COVID, particularly symptomatic and more severe COVID. So for example, here we observed about a 16% increase in COVID disease for a interquartile range change in NO2 and a similar association for PM2.5. So this is some evidence showing that long-term exposure to air pollution is related to COVID severity. And one of the possible explanations for this is that it goes through NCDs. So air pollution, we know from this vast body of evidence, is associated with many non-communicable diseases. And this could be sort of on the pathway that between the relationship that we're observing between long-term exposure to air pollution and COVID severity. So in conclusion, I see questions regarding the role of air pollution in this sort of interplay between communicable diseases, like pneumonia, for example, and non-communicable diseases, a really important area for future research. And with that, I will end here, and thank you very much for your attention. I know we don't have time for questions, but certainly feel free to get in touch by email if you have comments or questions. Thank you.
Thank you very much, Catherine, for your excellent presentation. We are really sure and really clear of what we thought it was a non-communicable disease, and now we have a clear chance to see how it impacted in the pneumonia and in the infections. Now, our next presentation will be by Dr. Chris Murray. Chris Murray is a director of the Institute of Health Metrics and Evaluation. He will try to explain to us how is the impact of air pollution in respiratory infections and the global burden of disease. Thank you, Chris.
Thank you very much. Let me start by giving a little bit of background about what is the Global Burden of Disease Study for those who may not be familiar with it, and then use it to explore some of the burden of pneumonia and air pollution. So the GBD, we like to think of it as a systematic scientific effort to look at the comparative magnitude of a wide array of health problems. It's meant to be comprehensive. It is driven by the philosophical idea that even when the data are poor, the world is better off having an informed estimate than no estimate at all. And that comparability across diseases and locations and age groups is really paramount. Now, anybody who's ever tried to look at a health problem across countries or over time or within a country across groups will be familiar with a host of data problems, inconsistent coding and case definitions, differing assays, no data for a problem in a place, or even harder when you have various studies that give very different results. Everybody in public health and epidemiology is trained in the problems of sampling error, but less emphasis is given to the bigger problem, which is non-sampling error, which ranges from everything from not going to communities in the rainy season because the roads are impassable, to excluded groups, which is number 5 here. Often disadvantaged or poorer individuals often don't get into administrative data systems. So the GBD provides a standardized toolkit that has evolved over the 30 years of the GBD study to try to deal with these issues. And over the last, I would say, 14 years, there's been a heavy shift towards using an array of Bayesian statistical methods to deal with this set of challenges. I will not go through that today, but there's an awful lot written about those. And feel free to reach out if you have questions. Another aspect of the GBD is that in addition to traditional metrics, let's say disease and injury incidence or prevalence, death rates or death numbers, we also have a series of rolled up metrics that are meant to give the bigger picture view of what are health problems in a country and over time. And those rolled up metrics here are shown. We calculate years of life lost due to premature mortality. We take the prevalence of every disease and all the disabling sequelae from that disease, multiplied by the public's notion of severity, and come up with years lived with disability. And then put the two together, we get DALYs, disability adjusted life years. And then we take all the exact same information and compute a positive metric, healthy life expectancy. Today, the GBD covers 204 countries. It produces each time it's run a time series for every outcome from 1990 to present. It includes subnational assessments in 22 countries, the partial list shown there. It covers 286 causes of death, 369 diseases and injuries, and 87 risk factors. And some of the analyses go back before 1990. So for example, age-specific death rates and fertility goes back to 1950, causes of death goes back to 1980, and that's really a function of the availability of data. Each round of the GBD, there's about 300 publications that come out across a diversity of journals. And by last count, since I think 2010, there's been nearly 2,000 papers from the GBD study. Now, one of the key attributes of the GBD, and this, I apologize, this slide is very out of date. I thought I'd put in the newer one. We are now up to 7,500 collaborators, and those are from 155 countries. And that is really a core part of the GBD effort. Now, since the GBD 2015, we have put all the sources used in the GBD, the metadata, into a thing called the Global Health Data Exchange. And we have posted all the code that we use on GitHub. So we are committed to making both the data and the computer code that we use publicly available and transparent. And we have, along with WHO, helped co-create the guidelines for accurate and transparent health estimate reporting called GATHER. And all the GBD papers that are produced are GATHER compliant. Now we've had a partnership for some of the high-level results that from the GBD coming out in issues of The Lancet. And those 5, 6, 7 papers give you sort of a high-level view. And then, of course, the other several hundred papers from each cycle in other journals give you deep dives by location, by risk, and by disease. For any of you who are not familiar, online, there's a tool at healthdata.org called GBD Compare. It allows you to query this database that has now got billions of estimates in it by age, by sex, by cause, by location, over time. And it's also in a number of languages. So for those of you who want to query the GBD data in different languages, that is available. Okay, so that's some of the background on the GBD. Let me go on to the findings for pneumonia. So one way to think about the burden of disease is this visual called a tree map, where the size of each rectangle is proportionate to the fraction of the total burden of disease that is due to each cause. So what you can visually see here, pneumonia, lower respiratory infections up here on the top right in the salmon colored box, that is the fraction of all the burden that is due to LRI. It's very large for a single cause. It is, as you'll see in a moment, it is one of the top 5 causes of burden still, despite great progress on pneumonia at the global level. So here's another way to look at that, and that's now taking that same information around burden and ranking causes. And so back in 1990, lower respiratory infections were the #2 cause of DALYs. And because there's been progress, particularly in children, less in adults, but still progress in children, we see that lower respiratory infections or pneumonia ranks #4 globally in 2019, and still is the top 5 causes of DALYs. So you can see other causes in this list, and the general shift over time that we're observing globally towards more NCDs going up on the list, the blue causes, and a number of the red causes, the communicable, maternal, neonatal, and nutritional causes going down because of progress, and then a sort of a mixed story on the injuries in green. Where is pneumonia a major cause of burden? Well, I think the answer to that is everywhere. But in terms of the percent of total DALYs that we observe attributable to pneumonia, you can see that in some places where pneumonia deaths in children are a major factor and the population age structure is still very young, in the Sahel, for example, we have more than 10% of all burden due to pneumonia. And you can see this distribution in other parts of the world where pneumonia is a major cause of death in places in other regions as well, as shown. So widespread, as one of the previous speakers mentioned, the balance here changes in terms of ages, where in sub-Saharan Africa, most of the pneumonia deaths will be in children. And if you look in a place in Europe or the UK or the United States or Latin America, there'll be more adult pneumonia deaths than child pneumonia deaths. Now, something that's new, not yet published, is our extension of the GBD to encompass antimicrobial resistance. And this work should be coming out in the scientific literature in the coming months. But we've gone beyond what's been done before in the GBD to look at the key pathogens responsible for LRI deaths, expand that set quite considerably. And one of the outcomes from this very extensive analysis of bacteriological data is a greater role for a number of gram-negative pathogens in lower respiratory infections than previously appreciated, as well as a role that due to antimicrobial resistance in those pathogens. Okay. Now, moving on to risk factors, the other aspect of the GBD. So we take the total burden of disease, we look at exposure for risk factors, we have systematic reviews for the relative risk around risk factors, and then we undertake the thought experiment: what if you reduced each risk factor to its lowest, the optimal level in terms of population health? That's which we call the theoretical minimum risk exposure level. If we do that, we can then calculate for each risk factor, including air pollution, and then roll that up into these risk factor groups: behavioral risks, metabolic risks, and environmental risks. And you can see that the ordering at the global level. If we go down a notch to more detailed risks, where we see air pollution, for example, both indoor and outdoor combined, we find that air pollution is the number 4 risk factor in the GBD study in 2019, accounting for both, in red here, deaths due to infectious diseases, particularly pneumonia, but also deaths due to NCDs in blue, and some of the deaths in purple due to some of the endocrine disorders. And you can see, if we go down a notch in disaggregation, that ambient air pollution is at the next level of detail of risk, the number 6 risk factor, and then household air pollution is a couple notches down below. So both very major risk factors, both indoor and outdoor air pollution. I think we will see in GBD 2020, the numbers for air pollution are likely to go up because of some of the newer systematic reviews. The other innovation that's coming in GBD 2020 is a much more in-depth exploration of the strength of evidence behind each of the risks. So we will be introducing in the future for each risk outcome pair a star rating that reflects what the meta-analyses and the between study heterogeneity in those meta-analyses suggests for how sure we are about the strength of the relationship between risk factors. So for those who do follow the GBD, some important innovations coming in GBD 2020. And this is, our latest results to date. Now, I don't have slides on COVID, but I think any presentation in 2021 that doesn't mention COVID would be remiss. We at IHME and through the GBD collaboration, we have spent quite a lot of time trying to make sense both of reported COVID, likely underreported deaths where the virus is involved, and then other deaths related to the behavioral change, government change, supply issues during the pandemic. And so the numbers are very large once you take that broader view, and those are going to be incorporated into GBD 2020. It's part of the reason we've been slower to put out GBD 2020 than in a normal year, because we want to make sure we have reflected the available data for 2020 on these broader impacts of COVID, which have been very diverse. So I'll stop there. Thank you very much for your interest.
Thank you very much, Chris, and thank you for being strict with your time. It was a lovely presentation, and those who do follow the global burden and disease have looked an amazing presentation on how to explain all this, what we see every year published. Now we face the new paradigm. The next two presentations speak on whether it's possible or not to reduce the outdoor pollution and the indoor pollution. This is a paradigm we don't know whether this is possible or not. For the part of reducing the household air pollution, we have Professor Balkrishnan, which is the director of the World Health Organization Collaborating Center for Occupational and Environmental Health. Thank you, Professor.
Yeah, hello, everyone. Can you hear me?
Yes, we hear you.
Okay. Just give me a minute. Okay, so good day, everyone. And I'm really happy to join this eminent panel today on the occasion of World Pneumonia Day to present some insights on the role of reducing household air pollution in reducing the global pneumonia burden for children. Since strategies to reduce household air pollution are often very context specific and deeply embedded within the energy policy framework of individual countries, I thought it best to focus on some key learnings from clean energy initiatives in India to identify some potential synergies with global pneumonia reduction efforts. So as you can see from the 2019 GBD assessment, India reduced the proportion of population relying on solid fuel use from 73 to 61%. But given India's population, the absolute number of people at risk from household air pollution exposures is still staggering. On the pneumonia front, just 5 countries were responsible for more than half of all child pneumonia deaths in 2018, with Nigeria and India leading the pack. Nigeria and India also have the highest number of estimated child pneumonia deaths attributable to household air pollution exposures. India bears some of the highest global burden of household air pollution exposures, child pneumonia burdens, as well as household air pollution attributable child pneumonia burdens. But it also has some of the most ambitious clean household energy programs rolling out in full steam. Through the national LPG program termed the Pradhan Mantri Ujjwala Yojana, as of April 2021, greater than 80 million households have been provided with new low-cost LPG connections, and nearly 95% of households in India now have access to LPG, thanks largely in part to the PMUY program. Given these facts, leveraging opportunities to reduce household air pollution exposures in India could provide some of the largest gains for reducing the national and the global pneumonia burden. Let me share some additional insights from ongoing efforts in India. We now have state-level estimates for both household air pollution exposures. As Dr. Murray noted, we have subnational estimates from the GBD and the estimated pneumonia incidence in India. The disparities in household air pollution exposures in states is mirrored by the disparities in pneumonia incidence, with the northern, eastern, and central states faring the worst. In 2015, the estimated incidence of pneumonia in children, younger than 5 years was nearly twice as high in these high focus states of Bihar, Chhattisgarh, Jharkhand, Madhya Pradesh, Orissa, Rajasthan, Uttarakhand, Uttar Pradesh, and Assam than in all the other states. And although the prevalence of pneumonia risk factors in many states declined between 2000 and 2015, in the high focus states, the prevalence of many risk factors, including household air pollution, actually increased or remained stable, and thus should be the target of strategies to address the burden of pneumonia in India. There is also further nuance in household air pollution exposure disparities. Not only are there differences in the proportions across states in solid fuel use as their primary source of fuel, but the levels of stacking clean fuels with dirty fuels is also highest in the high pneumonia state. The PMUY has provided subsidized access to LPG, but transitioning to exclusive LPG use would require considerable additional resources in terms of more widespread subsidies and greater improvements in distribution delivery in states that lag behind. Finally, household solid fuel use in India is also the single largest contributor to ambient air pollution. There have been 7 published studies to date that model the proportion of ambient PM 2.5 in India and deaths attributable to household cooking, and estimated to be in the range of 22 to 52%, and significantly higher contributions than from transportation, power, and the industry sector. This is, of course, in addition to the substantial risks that households experience directly from cooking. While all pneumonia risk factor estimations include household air fuel use, they do not currently include ambient air pollution contributions from household fuel use, and which we know has been observed to be associated with both short-term and long-term increased risk of pneumonia in children. The high levels of stacking of clean and dirty fuels that are not fully apparent in the metrics of the PMUI program and the contribution of household sources to ambient air pollution indicate that these could be a source of considerable underestimation of the pneumonia morbidity estimates in India. So what can be done in India? The National Clean Air Program in India was officially launched in 2019 and specifically includes clean cooking as a priority sectoral intervention. But what could be strategic is to pitch the mitigation of household fuel sources as a win-win for both reducing household air pollution and ambient air pollution. Shown here are results from a recent study that show that the Indian National Ambient Air Quality Standard to be completely achievable by mitigating emissions from household cooked fuels, and thus eliminating solid cooked fuel use would be the lowest hanging fruit for achieving the national ambient air quality standards, and needless to say, with tremendous co-benefits for pneumonia. Leveraging on research evidence from strategic epidemiological studies concerning household air pollution pneumonia that are underway globally could provide some very powerful risk communication tools. And one such important effort is the ongoing effort is the multi-country household air pollution intervention network trial that includes India as one of the sites. The trial enrolled nearly 3,200 pregnant women in Guatemala, India, Peru, and Rwanda, and is following them, their infant child, and an older adult woman in the home until the child's first birthday. The intervention consisted of an LPG stove and 2 initial cylinders of LPG, free fuel refills delivered to the home, and regular behavioral messaging. And we have thus far assessed intervention fidelity, delivery of the intervention as intended, and adherence, basically intervention use, to the end of gestation as relevant to the first primary health outcome of the trial, infant birth weight. Fidelity and adherence were evaluated using stove and fuel delivery records, questionnaires, visual observations, and stove use monitors. And here are some very first preliminary results. And as you can see, they are in preprints, and kindly do not cite or quote, but they indicate that during the trial, over 96% reported cooking exclusively with LPG at the 2 follow-up visits during pregnancy, with complete abandonment of traditional cooking observed in over 67% of the intervention household. LPG was adopted almost exclusively, even by households that had no previous experience with LPG. But most importantly, the intervention also achieved large and sustained reductions in household air pollution, with nearly 70% of the measurements of fine particulate matter in intervention households remaining below the WHO interim target guideline of 35 micrograms per meter cube during the course of pregnancy. Epidemiological modeling has shown that reductions of this magnitude could have a dramatic impact on childhood pneumonia. While the results of the trial on health outcomes are awaited, initial results on intervention adoption and exposure reduction provide some of the most encouraging news regarding interventions to reduce household air pollution. And finally, if efforts to reduce household air pollution can be simultaneously matched in India with efforts to improve water and sanitation, as well as immunization coverage, as has been proposed in the global plan for ending preventable child deaths by UNICEF and WHO, the expected reductions in pneumonia can be tremendously greater. An unprecedented opportunity exists in India to do just that. Synergies in available policies focused on clean water and sanitation, the National Swachh Bharat Mission, clean household energy, the National PMUY mission, and childhood immunization, the National Indradhanush mission, hold enormous promise for dramatically reducing the burden of child pneumonia in India. Clearly, the insights I shared from India regarding opportunities to impact child pneumonia through reducing household pollution may not be representative entirely for what might work in other regions, but identifying opportunities to reduce household air pollution in each of the geographies where this risk factor prevails is critical for improving the health of children for generations to come, and for us to meet the SDG goals much earlier than the stated timeline of 2030. So thank you very much.
Thank you very much, Kalpana, for your nice presentation. One quick question. Do you think that your model can be expelled to any other country around the world?
Not maybe entirely, mainly because of the extraordinary opportunity for leveraging with the national LPG program, which I think is unprecedented in scale. But clean energy initiatives are rolling out at scale in many countries. So if we can think of learning lessons by leveraging the pneumonia story with the national LPG program and many other health outcome story with the LPG story, I think that can hold lessons that are not easily available through natural experiments for the rest of the world.
Thank you so much for your nice presentation. Now we pass through the next speaker. This next speaker is the Master Shane Maguire, which is the Director of the Strategic Partnership and Communications of the Clean Air Fund. We are all focused now on Glasgow and seeing what will come from out there. But please, Sean, can you tell us how can we do that now from our houses?
Certainly, I can. And just bear with me while I sort out the display here. That's not showing the screen, the slides properly yet, is it?
Perhaps if you, yeah.
Okay, let's see whether we can fix this. Hold on 1 second.
In the display setting, down in your screen, it may probably help.
sorry about this. I did have this before. Stop share. Let's try it. Let's start again.
Yeah, we see you, but we don't see the presentation. Yes, brilliant.
There we go.
Thank
All right,
you.
thank you very much. Great. So thanks very much for inviting me to join you today and for the opportunity to speak about an issue that affects us all every day, and that is air pollution. I'm Sean McGuire, and I am the Strategic Partnerships Director at the Clean Air Fund. And I wanted to start by showing you this, which is something that a colleague in India sent me this week. He sent me the figure on the left. And this is the online air quality indicator for Delhi for Wednesday of this week. And as you probably know, this is the worst time of the year for air quality in Delhi because of the fireworks from the Diwali festival and also because of the crop stubble burning in the states outside the city and with the wind blowing the smoke into the city. And as you can see, the air quality index is really, it's nearly off the charts. And residents are breathing air that is officially described as hazardous to their health. The index is reading 719, and that means the level of particulate matter 2.5. And as you all know, that's the small particles that get into your bloodstream via your lungs and which causes you cancer and heart disease and embolisms. That level is 421 micrograms per cubic meter. And just as a reminder, the current WHO guidance level for safe levels of PM 2.5 is 5 micrograms per cubic meter. So Delhi's air pollution, the level of air pollution that Delhi residents are currently breathing is 84 times the level the WHO advises. Now, for a long time, Delhi has had the dubious distinction of having the worst air quality of any capital city in the world. It's estimated that poor air irretrievably damages the lungs of 2.2 million children, or 50% of all the children in Delhi's, in India's capital. There are 31 million people living there, and this is the reality of air pollution in 2021. So what should we be trying to achieve? Well, this is it, clean air for all. That's what we should be trying to achieve. And this is the goal of the Clean Air Fund. I imagine not all of you are aware of the Clean Air Fund, or CAF as we are known to our friends. So I thought I'd give you a little introduction to who we are and what we do. Now, we were funded 3 years ago to accelerate action on clean air. And we were established by a group of funders with interests in climate, in health, in mobility, and in children's development. And they identified air pollution as an issue that was impacting the people they exist to serve. Now, what is it we try to do? How do we achieve clean air? Well, we have two main goals, twin goals, and that's to improve human health and reduce greenhouse gas emissions by reducing air pollution. And to do this, we focus on 4 drivers of change. The first is we help to create and share local data so that air pollution and its impacts are visible to all. And we build pressure for clean air, increasing public demand and the political will to act. And we support governments and businesses to put the right laws, policies, standards, and commitments in place. And we strengthen the clean air movement by increasing funding going into clean air action. And where is it we work? Well, we work globally and we work in specific geographies. At the moment, we work in the UK, Eastern and Southeastern Europe, in India and in Ghana, where we'll be working from next year. And you may ask, oh, why this collection of countries? It seems a bit random. Well, the idea is that by working in different country types, we will learn the lessons of what's successful in reducing air pollution in each of these states. And then we can replicate those lessons into countries that are similar to each of these countries where we're working. So how well are we doing in the struggle to achieve clean air for all? Well, on the face of it, not very well at all, unfortunately. I'm sure you've heard lots of numbers already, but just to reiterate them, the numbers on health impacts are absolutely huge. We know air pollution contributes to the death of at least 4.2 million people a year. And let's remember that this figure is from 2016. So the number, alas, will be much worse than now. Since 1990, death rates attributable to air pollution have risen 150% in lower and middle income countries. So where is air pollution worst in the world? Well, unfortunately, outdoor air pollution is a problem just about everywhere, but it is worse and getting even more severe in the developing world. And it's usually an urban problem. 80% of all city dwellers worldwide are breathing air the WHO describes as harmful. And given its prevalence, it's no surprise that the WHO has described outdoor air pollution, ambient air pollution, as a global health emergency. Now, this map gives you a bit of an idea of the spread of mortality due to PM2.5. And the countries that are filled with the darkest colors suffer from the worst effects of PM2.5. And that is currently India and China, the two most populous countries in the world. In 2019, there were 1.42 million deaths attributable to PM2.5 in China and 980,000 deaths in India. Increases in death rates in Africa, in South Asia, and in East Asia vastly outnumber the modest decreases seen in higher income parts of the world. This chart shows you how the impact varies by age. The twin peaks show that unfortunately it's children and the elderly who suffer disproportionately. And that very sad peak you see on the left is of population-related deaths in very young babies, and that is the impact of exposure during pregnancy, which is leading to low birth weights, preterm births, and lower respiratory infections. Now, is the problem getting better or is it getting worse? Well, unfortunately, the forecasts are rather gloomy. You can see from the set of 3 bars on the left that there is an expected increase in deaths from outdoor pollution, air pollution. The green bar on the far left is 2010, the middle bar is 2030, and the highest bar is 2050. So you can see that the deaths from outdoor air pollution are predicted to more than double between 2010 and 2015. And other major causes of death, such as unsafe water or malaria, are expected to decrease. Now, where is all this air pollution coming from and what are we going to do about it? In the interest of time, I'm not going to dwell on each of these areas in detail, but essentially the cause of air pollution is human beings burning stuff, usually fossil fuels, in order to generate heat and power and to get rid of waste. So that is what we have to find a way to stop. But you will say to me, that's difficult to do, isn't it? It's difficult to stop burning fossil fuels. Well, yes, but I think we can help convince ourselves to take the right actions if we look at the benefits that we might enjoy. There are huge gains to be made for health, for social justice, for clean growth, and for the sustainability agenda from addressing air pollution. Now, because the sources of air pollution and greenhouse gases are often the same, i.e. burning fossil fuels, the solutions can often be the same as well. So action on air pollution is action on climate change. There's a double benefit there. And the final benefit I want to mention is that by tackling air pollution, we can really help those most vulnerable in society, especially children. Now, how do we go about combating air pollution? Well, obviously, lifestyle changes play a huge role in this. We can all switch to electric vehicles. We can walk, we can take public transport, we can fly less, and we can change the way we power and heat our homes and our workplaces. And these are all absolutely vital measures that we have to take. But they're not enough, and they won't happen automatically. We need policymakers to take air pollution seriously and have the courage to persuade voters to accept that the way we live is choking us in fossil fuel emissions that are shortening our lives. And campaigning for cleaner air has a long and distinguished history. This picture is from April 1970. It's a picture of protesters on the first Earth Day. And you can see the point they were making. Air pollution kills. It was killing in 1970, and it's killing now. Now, obviously, we face vested interests, such as the fossil fuel industry, which are very, very strong. And we are all heavily invested in the status quo. But the response to the COVID crisis has shown us we can lead different lives. It is possible to change. Governments control the tax policies that encourage car use. They are the ones that direct investment into coal mining and oil and gas exploration. They're the ones who reduce subsidies for public transport. And they're the ones that legislate to encourage road building, all of which contribute to air pollution. But the governments, they can and they should take a different path. And there are opportunities for action. In both the UK and the EU, there are policy decisions being taken now and being considered that could reduce air pollution considerably. There's a UK Environment Bill going through Parliament, which the UK government is refusing to put WHO targets into. The EU's Ambient Air Quality Directive, which sets the targets for all countries in the EU, is being revised for the first time since 2008, since when science has shown us much more, given us much more evidence about the damage that air pollution does to our health. So there is a real opportunity here to focus on these new WHO air quality guidelines, which are setting a gold standard for air pollution that all countries should be aspiring to. And there will be fierce resistance to these measures, to tougher measures, but I think there's an opportunity for energetic campaigning by a broad coalition of civil society to persuade politicians to do the right thing. I've got two last slides. I want to speak specifically about the role of healthcare workers and their professional associations. Healthcare workers see the harm caused by air pollution in their work. They can bear witness to the human cost, and their voices are respected. They are listened to, and many are already speaking out. On this slide, you can see 3 examples of doctors campaigning, health associations providing information, and healthcare workers on the eve of COP demonstrating by cycling from London to Glasgow as part of a campaign to end fossil fuels, what they think the government should do. So I would encourage more of you to engage your governments. Sometimes the best way to treat patients is to tackle the root cause, not to address the symptoms. And there are many ways to act, from campaigning publicly, to advocating via NGO groups, to using your professional associations to raise concerns, and to educate the public and politicians on the road that we should be taking. Now, I want to end with a story of tragedy and hope linked to air pollution. This is the story of Ella Kissy-Debra, who died 8 years ago, aged 9, from severe asthma that was linked to air pollution that she was breathing in, air pollution that was coming from the busy road that she lived nearby. And it's important that we put a name and a face on the child victims of this terrible problem. Children breathe more often, and they're closer to vehicle exhausts as they are nearer the ground, and they're more susceptible to the health impacts of air pollution, like asthma. Through our work, the work of CAF, supporting campaigns and advocacy around protecting children's health, we're starting to have a real impact. Ella has become a cause célèbre of the air quality movement. And her mother has bravely taken on the establishment, and she successfully fought for an inquest to be reopened into her daughter's death. And the coroner's ruling that her death was caused by air pollution has set a legal precedent, which we hope will push the UK government to regulate traffic and emissions levels more robustly. And we at CAF are proud to be supporting Rosamond's struggle. So I want to thank you for your attention, and I look forward to you joining us in the struggle for clean air for all. Thank you very much.
Thank you very much, Sean. It's a very interesting presentation and how this reducing outdoor air pollution involves not all the scientific societies or governments, but it starts with us. Our next presentation comes with the role of the coalitions. Now we're working in a big one coalition. And the important is that this coalition help governments, or they force governments to change the politics about air pollution. And now we have Sandra Cavalieri, which is from the Climate and Clean Air Coalition, and she's the Urban Health Initiative Coordinator, who will explain as well as the role of these coalitions in the air pollution in this global conference.
Thank you so much. It's a pleasure to be here and to speak on behalf of the Climate and Clean Air Coalition Secretariat. Again, my name is Sandra Cavalieri, and I work on coordinating our work on health and our work on household energy at the coalition. Next slide, please. So for those who are not familiar, the Climate and Clean Air Coalition was established in 2012. It was established as a global and voluntary partnership dedicated to addressing short-lived climate pollutants. And these pollutants included black carbon, methane, and HFCs. And from the day that we started with 6 countries and UNEP, we now have 73 state partners and 78 non-state partners, all committed to taking action on short-lived climate pollutants. And the way that we work is through governments. We target specific polluting sectors that are emitting the short-lived climate pollutants, which are both impacting health as well as climate, and actually also, in addition, is impacting agricultural crop production. And when the coalition was started in 2012, there was gridlock in the UNFCCC, and countries were having, I guess, as much trouble, more trouble than they are today, let's hope, in coming to agreement on a path forward. And this Climate and Clean Air Coalition was born out of a desire for collaboration and to work across the climate and air quality silos, and to also bring countries together to work on the issues that matter to them. So for some countries that joined, health was the priority. For others, it was agriculture, and for others, it was climate. But the reason for joining the coalition didn't matter as long as the effort was to take action in these specific areas to mitigate the short-lived climate pollutants. Next slide, please. And so today we are celebrating a lot of success in working with national governments. So over the past year, 60 CCAC partners have submitted new or updated NDCs, and all of them include methane, 12 include black carbon, and 44 include HFCs. And we're funding specific projects in 17 countries to help the countries actually take action on national plans to mitigate short-lived climate pollutants. We've also looked, and we see that 67 countries have household energy-related targets, and this is a place that we really want to work with countries to help implement the commitments that they have made at the COP through their nationally determined contributions, or NDCs. We also see that countries are increasingly, with the support of WHO and also experts through the Climate and Clean Air Coalition, are taking action to quantify the health benefits of NCD implementation. So in Colombia, in Cote d'Ivoire, in Ghana, in Nigeria, and Togo, there's been a lot of work to quantify the health benefits. And so when we think about the role of coalitions, I think in thinking about the Climate and Clean Air Coalition, our main function is to be a matchmaker. We're looking to connect governments with experts, and at the same time, we're really breaking down silos. So we have experts coming from many different ministries and many different research approaches to try to tackle this problem. And I think a third really important piece of the coalition is that we create new coalitions. And so I'll discuss that a little bit further, but I think those are our real contributions as a coalition. And the CCAC in particular has really brought together these two worlds of climate and clean air. So before we were established, there were a lot of people working on climate, there were a lot of people working on clean air, but I think that this has been the beginning of a movement to kind of push these two streams of work together. And now we see even more this linkage between health and climate and air pollution that was really unheard of in 2012, which is now almost just mainstream to a large section of the people working on this. And so the coalition has brought together the climate and clean air communities, but we've also created this kind of assembly line approach to helping governments get on track towards these mitigation options. And so we have a process whereby we support national governments to make a plan to reduce short-lived climate pollutants. And through this plan, they're not only calculating greenhouse gas emissions, which would have been required under the UNFCCC, but they're adding short-lived climate pollutants. So this is a sort of like additional benefit of working with the CCAC. And then we bring the experts in to the countries and help build country capacity to collect data, analyze data, and start to put into place these mitigation measures and calculate the benefits. We also at the CCAC, an important part of our coalition is that we give governments recognition. We recognize the success, we share information, we share best practices among governments. And then by doing this, we're increasing the momentum and the funding for this issue. So without coalitions, the role of coalitions, I think, is to really move things forward faster than they would have moved before. And we recognize that government officials are often, extremely busy. And so the fact that they're listening to us is kind of like already an achievement in itself, because, especially in the health sector, I'm sure all of those previous speakers can attest that countries have so many health burdens that to add air pollution to the list is often difficult, but the WHO has really been at the driving force of making sure that countries do recognize the benefits from mitigating air pollution. Lastly, I want to say that countries are recognizing now the health benefits that they can get from climate packages. So there's a lot of finance going into climate. And so the trick now, I think, for governments is to figure out how to best serve their local population while also contributing to this global, slowdown of the rate of temperature increase for global warming. So next slide, please. So as far as creating coalitions within coalitions and coalitions outside of coalitions, together with the World Health Organization and the UN Environment Program, the CCAC launched Breathe Life in 2016. And in 2018, the World Bank joined. And this is a campaign and a platform for action. So what we're doing is we're trying to raise awareness about the links between air pollution and public health, but we're promoting solutions that target short-lived climate pollutants. So in the beginning of this campaign, there was a worry that people wouldn't understand health, climate, and air pollution all in one sentence. So the focus in the beginning was on health and air pollution, and we've slowly been able to bring climate into the discussions, so that now at the Health Pavilion at COP that the WHO is leading, you can see many events that are focused on this integration. But with Breathe Life, we set this target of cutting deaths in half, and by 2030. And this also kind of mirrors what I saw earlier with trying to cut the deaths from pneumonia. And so I think that we're really at this point where we can expand our coalition and really engage much more closely with health experts and the health sector. So next slide, please. So as far as our major achievements from Breathe Life, We have 74 cities, regions, and countries, and growing. We almost can't keep up, honestly, with the demand for governments to join the Breathe Life Network to help them achieve the WHO air quality guidelines by 2030. So what we're trying to do is help governments on the path towards achieving interim targets and then final targets. And I think a really big outcome of all of this work is the establishment of the International Day of Clean Air for Blue Skies, which is an annual day held on September 7th to recognize the efforts of governments and civil society organizations around the world. So I think just like World Pneumonia Day, with a day dedicated to clean air, you can continue to drive this momentum and build coalitions. And I was speaking with my colleague about this presentation, and he said, actually, the CCAC and the role of the coalition is we're sort of like a virus, which I thought that might appeal to this audience. We feel like it's just sort of, we can go back to 2012, and over time we can kind of start to see the connections being made and the expansion of this idea of short-lived climate pollutants. And so even just as recently as at the last COP, IKEA representative was having a coffee with my colleague, and they had just a chat about, well, wouldn't it be great if IKEA could reduce air emissions throughout their supply chain? And now a guidance document is being developed, and through that, the World Economic Forum has just launched an alliance for clean air, which includes IKEA and 9 other companies that are going to be committed to reducing air pollution throughout their supply chain. So there's just like honestly hundreds of examples of this type of connection that can be made between individuals to help expand the work. And then there are also excellent examples of scaling up the actions themselves. So we have had really a lot of success in reducing black carbon from brick kiln production in Nepal and in Pakistan. And this is something that, is an untouched issue in many places, but it's a huge crisis for social welfare and public health and the climate. And so this is something that we've been able to tackle, and it just kind of keeps expanding outward. And so my next slide might be my last. And so I wanted to, yes, this is my big point, is that the coalition is more than the sum of its parts, which is of course something that we've all heard before, but I think the value in knowledge exchange and building on science, the value in really taking time to build capacity in countries to support national planning efforts and integration of policies from health, from environment, from energy, from transport is really critical. And that we need to catalyze our impacts and really scale up. So whenever we see something that's working, we need to figure out how we can continue to increase the uptake of that best practice. And we're seeing that more and more. And we also want to leverage finance, because nothing happens without money. So we're expanding our influence. We're doing our best to exponentially touch governments and organizations around the world. And just in my last minute, I will say that I'm also very inspired by the story of Ella and her mother, Rosamund Kissy Deborah. And I thought I had heard the whole story, but recently, just the other day, I listened to her tell the story again on a podcast where she really, I learned so much more than I had realized before. She talked about how Ella had 28 really horrible asthma attacks and had gone to the hospital 28 times over 28 months. And she went to 5 different hospitals in London, and not one person mentioned air pollution to her. And it was through her perseverance and hard work, and also the support of her legal team, but her in particular, who really was trying to find the reason that her daughter died. And people had mentioned food allergies and all kinds of different, you can imagine the world of ideas that came to people's mind of how could this have possibly happened. And she looked back at the monitoring data and realized that there had been a massive spike the night before Ella died. And then when they looked back, they were able to tie high air pollution episodes to monitoring data. And that's how the inquiry was eventually able to be reconsidered and then overturned. And what I thought was so shocking was that she actually was in 5 separate hospitals in London, and no one said a word to her. And the tragedy is clearly, you can tell, like, she would have done something. So I think we're just at this point where we really have to raise awareness and do the best we can. So thank you very much.
Thank you very much, Sandra, for your very nice presentation. We've been speaking about how we can tackle ourselves air pollution, how we can do and scientific societies can do and work about that. We now are seeing what is happening in Glasgow, and now we need to speak what is the role of the academic institutions. For that, we have 2 speakers. The first is Professor Kim Mulholland. She is professor from Child Health Murdoch for the Murdoch Children Research Institute, and he will explain to us what is the role of these institutions in tackling the air pollution. Thank you, Professor Kim.
Thank you very much, and thanks for the opportunity to speak to you. Are you seeing the correct screen now, please?
So yes.
Okay, I'll assume.
Yes.
Yep, fine, thank you very much. I have the rather curious title of the role of academia in pneumonia control, and I've added in low and middle income countries. I'm going to speak not just about environmental issues, but also about the other important factors that have been alluded to at different times during this talk regarding pneumonia control, particularly the environment, of course, but also the nutrition issues and the role of vaccines. Going back a little way, though, we don't have to go back too many years to see a time when childhood pneumonia was a major cause of death in the United States. In 1900, this graph shows the trajectory from 1900 up to 1960. The blue line is childhood pneumonia mortality under 1, and the yellow line is the rate between 1 and 4 years. So these were very high rates of pneumonia mortality, even by the standards of the poorest countries in the world today. I've often shown this to students, and they always say, well, this must be the role of antibiotic treatment. But on this graph, I've shown you when antibiotics were introduced, and most of the improvement had taken place before then. And when you look at the pictures from US cities in late 19th and early 20th centuries, it's easy to see what the problem was. But jump forward a few years, and in the early 1990s, I found myself living in West Africa, and this photograph that I took of a child in Guinea-Bissau highlighted, for me at least, the important risk factors for childhood pneumonia. And this child, although living in a remote rural area, was living in an extremely polluted home environment, very crowded home environment. He was suffering from malnutrition, and he had no access to any immunization or indeed any healthcare should he get sick. So he was a high-risk child, and for me, this was one of the things that sort of set me off on a course of working on childhood pneumonia. The same year, 1993, the World Development Report was released by the World Bank, and it's interesting that out of the top 6 contributors to the global burden of disease in this report, indoor air pollution was highlighted as second there, causing respiratory tract infections. Now, it amazed me at the time that there was so little work going on. In fact, I remember I did write an editorial for The Lancet this particular year on the subject, and there was really very little research going on. The academic world didn't seem to have taken this on, and there seemed to be rather little objective proof for what was being stated there. WHO at that time and working with some academics and particularly the team led by Kirk Smith in the United States really eventually did take this on and manage what I think was the first real randomized introduction, basically a randomized introduction of intervention or a randomized trial. And in the Guatemalan highlands, this was the setting that was sort of standard for the communities that were involved in this study. And the intervention is seen on this slide on the right. It was called a plancha, and it was a locally made stove. But you can see that obviously it improves many aspects of the health of this family. But in this study by the late Kirk Smith, there was a significant reduction in pneumonia. And I think this study stood as being a really critical study. Maybe it was obvious to everybody that this was going to be the case, but it was really important to show that. Jump forward a few years and I find myself working on the same subject in a different kind of part of the world, which is Ulaanbaatar, Mongolia, which is a highly polluted area. Interestingly, I took this photo a couple of years ago. Interestingly, in Ulaanbaatar, the increase in air pollution that's been seen in recent years is really a consequence of climate change and the increasing migration of semi-nomadic communities into the city, burning predominantly or almost exclusively coal. And this is disastrous, of course, for the health of children. But the link to climate change really does highlight something that's already been raised in this discussion, which is on the front line of the problems of climate change are the poorest communities. And the poorest communities are where there is malnutrition, where living conditions are poor, and where often it's very difficult for people to find fuel to cook and so on. So, we see these two current global situations as inextricably linked, sadly. Almost every study that's been conducted that's looked at the causes or the risk factors associated with pneumonia death highlight malnutrition first. And you saw the importance of this on some of Chris Murray's slides earlier as well. In fact, we did a study on this in the Gambia some years ago, but there has been rather little recent work on this, despite the fact that malnutrition continues to be a major problem. And this is really frustrating for me. As I look at the role of academia, I would have thought that we would be focusing on really the key issues that are associated with the major childhood problems of our era. But that's not really the case, I fear, and others may disagree, but I really feel that this has been neglected. This kind of situation is still prevalent in parts of the world. And sadly, as we face a period of increasing instability, we've mentioned climate change, but there are other factors as well at play, not to mention pandemic. We can imagine that there is going to be more malnutrition. In fact, there were some editorials published in The Lancet by the heads of relevant UN agencies last year. But there was rather little data to support that. There was really just a projection or prediction that there was going to be more malnutrition. But there is data, and it's coming now from local studies, like this excellent study from a group in Indonesia. And this is a sort of micro study, you could say, within one province of Indonesia, showing in orange the prevalence of malnutrition, in this case stunting, in different districts really of this province after or during the pandemic, as opposed to the blue bars, which show the prevalence before the pandemic. And there is a patchy, unequal increase in malnutrition, and this we've seen anecdotally in other countries. So malnutrition on the rise. That trend is not going to stop soon. I just also want to say, while I've got short time, that a few comments about the role of academia in vaccines. We could say, well, here is an area where the academic community should be playing a leading role, and they have. And I'm not going to speak about measles and Haemophilus vaccines, but although both of those vaccines have played an important role in control of childhood pneumonia, Indeed, the first study I did of childhood pneumonia was in 1988 in Manila, and almost every child I saw there in quite a large study was trying to recover from measles basically at that time. And we see academics have played really a major role in the development of vaccines against pneumonia. And this picture shows Dr. Schneerson and Dr. John Robbins, who were employees of the US NIH at the time when they really made some important discoveries that led to first Haemophilus conjugate vaccines, then the pneumococcal conjugate vaccines. And this, of course, has led to a range of other vaccines of that type. A fantastic achievement, I would say. And that was taken forward by another American academic working in the University of Rochester, Porter Anderson. And Porter's work really was to construct the first pneumococcal conjugate vaccine. The year here is 1989. From the bottom here, you can see what happened to that vaccine. It went from Porter's lab to the Praxis Biologics, a small company, American Home Products, Wyeth, and ultimately then to Pfizer. It became, for Pfizer, a major product. In fact, it was the first blockbuster vaccine, as it was referred to in the year 2000. Now, in the lead up to the licensure of that vaccine in 2000, there was a series of trials that were undertaken by academic groups. And I've listed them here. I'm not going to go into them in detail, but these are all really leading academic groups at that time that were undertaking these trials. And you may be surprised to know that what was the Wyeth became the Pfizer product was not the only one. There were several others. But these trials were all conducted by academic groups. Mostly they were funded by international let's say by government funding, NIH, MRC, the European Union, and so on. So industry was involved, but they were involved as sort of partners. They really had rather little to do with the way those trials were conducted until the year 2000, and then it all changed. And I would say in recent years, there's been a dramatic change in the way this has happened. After 2000, the first of the pneumococcal trials that took place that was really done by industry was done in Latin America. It was called the COMPASS trial. And really that's heralded a complete change in the role of academics in this field. Vaccines quickly became billion-dollar products. As I said, the licensure of Premature in 2000 yielded what was called at that time the first blockbuster vaccine. The role of academia has diminished as a result. Academics now find themselves involved in large trials run by industry, often with hundreds of sites in many countries, and it's all kind of tied together by contract research organizations who themselves throw together a really greatly increased cost of the trials and therefore increased cost of the vaccines. And the increased cost of the vaccines continues to be a major problem. And now, as I speak, 21 years after the first licensed pneumococcal conjugate vaccine, only half of the world's children still already have access to that vaccine. The last of the pathogens, and this is one which has been very closely linked with air pollution, is the respiratory syncytial virus, or RSV. It has the prevention of this RSV disease. It has really had three phases, I think, in vaccine development. The first phase was in the 60s, and an early vaccine was introduced, which sadly produced worse disease in children and was abandoned, of course. In the 90s, there was another sort of phase with two vaccines that were being developed, but for various reasons that stopped. And now currently we're in the sort of third wave of RSV vaccine development, around 60 years after the virus was first identified, with the vaccines being developed directed at adults, at maternal immunization, interestingly, and at infant immunization. And I just want to speak a little bit about the study that took place that was directed at maternal immunization for the prevention of RSV disease. And this is an extraordinary study for many reasons. Now, this was the Novavax trial. People have heard now Novavax's name associated with COVID-19 vaccine, but the Novavax RSV trial was a maternal immunization study that was funded by the Gates Foundation. It involved only about 4,000 children. So in the world of phase 3 trials, it's a relatively small one. But it was done in 87 sites in 11 countries. The result, circled in red here, the bottom line result was really just under 40% efficacy for prevention of RSV disease in the first 3 months of life. The FDA had mandated that it should be over 40%, so the vaccine sort of failed. But in the fine print, when you look through and look at what actually happened in the trial, a few things happened. Firstly, there was a second analysis that was done that produced a slightly different result with about double the number of endpoint cases, because in all of these sites that were coordinated by a company that had never really done a trial like that before, almost half of the cases were missed. And once those cases were gathered together, there was more information, and that's got creeped over 40%, but that was perhaps not enough. And also, I just highlight at the bottom there that in the same study, there was an over 70% protection against hypoxemic lower respiratory tract infection, and 60% against all hypoxemic lower respiratory tract infection. So the vaccine actually worked, but nevertheless, the product was abandoned really because the trial was not done well, because academic groups were not leading this trial, in my opinion. So after the year 2000, we see pneumonia is an increasing problem, increasingly a problem of the poorest communities, especially in humanitarian settings that were mentioned by Anshu in his opening address. Secondly, research, in my opinion, has been inadequate given the size of the problem, and us in the academic community really need to lift our game and get more involved in not only vaccine research, but in all aspects of pneumonia research. The PCV I've mentioned is still only available for 50% of children. There is now an urgent need for a renewal of research in the pneumonia field. I think WHO is taking on a leading role in this. And I think we could probably do well by starting with taking a leading role in the RSV vaccine trials that are underway. And so having said that, I thank you for your attention, and I hope I've stayed the time. Yes, this is Martin Weber in my book that's been shown there. But thanks very much for your attention.
Thank you very much, Professor Mulholland, for your brilliant presentation. We have a lot to do for the future that is near. On the other side of what is the role of the academic institution will be in the charge of Professor Peter Sly. He's from the University of Queensland and is a WHO Collaborating Center for Children's Health and Environment. Thank you, Professor Sly, for accepting this presentation.
Yeah, thank you, and greetings from Australia in the early hours of Saturday morning. I'll try and get my slides up. It's 3:30 a.m. in Brisbane.
This one, yes.
Okay, is that you've got the right view now? Okay, I echo what Kim has said about the role of academic institutions. I'm going to talk about environmental determinant of child lung health and get an idea of how we're going in this area. To me, the role of academic institutions is probably twofold. First of all, conducting research to provide the evidence. And here I think what we need to be looking at are environmental determinants of child lung health, climate impacts on child lung health, and how to improve child lung health. But the second role of academic institutions is capacity building, and particularly workforce training and, again, specifically in the lower middle income countries, although I'm not going to speak about that specifically this morning. A little while ago, our collaborating centre was involved in this exercise with WHO on producing an atlas of children's health and environment. And you can see that pneumonia was still a large part of childhood deaths, child under 5 deaths in the year 2015. And we've seen data today on how there have been gains, but how these gains haven't been adequate. I thought I would start by reminding people that one of the reasons why children are particularly susceptible to the adverse impacts of air pollution is that they breathe more air relative to adults to their body size, and therefore they receive a higher dose of any airborne toxicants, including air pollution. And if you look at these data in minute ventilation and litres per kilogram per body weight, you can see in the first year of life, an infant breathes 3 times more air relative to their size than an adult does. And so they do receive a much higher dose of pollutants that are in the air. There has been a lot of research on epidemiological type research on risk factors, and still risk factors for respiratory disease in children. Tobacco smoking is still a major risk factor and a preventable cause. This is both personal risk of personal smoking of older children, environmental tobacco smoke, and maternal smoking during pregnancy, which is still far too high in many parts of the world. We've heard about indoor air pollution and biomass fuel use for heating and cooking. Also the air toxicants that come from burning indoor different fuels. And to a large extent, it depends on what's burnt as to what's in the air. Burning coal, particularly in areas like southern China where there's high sulfur content of the coal, gives one level of pollution. Burning crop residue will give persistent organic pollutants, dioxins and furans, which also add to the disease burden. We've heard a lot about outdoor air pollution already, traffic-related pollutants in particular, diesel exhausts, but also industrial pollution, allergens, and occupational agents. And as you've heard highlighted by a couple of speakers, particularly Kim, the diet and nutritional factors and poverty all contribute and magnify the risks of air pollution exposure. We've heard some talk about other non-communicable diseases, but asthma and COPD very much have environmental contributions, and a lot of this relates to the way the lungs develop and grow. And low lung function, particularly at birth, increases lifelong risk of respiratory disease. The lung function grows along trajectories in a similar way to height growth. You plot it along trajectories, the lungs grow the same way. And poor lung growth increases disease risk. It's now established that at least 50% of chronic obstructive pulmonary disease in adults comes from low lung function in children and adverse exposures during childhood. The lung is one of those organs which is not mature at birth, and so its growth is susceptible to both prenatal and postnatal environmental exposures. In a little schematic here, there are 2 main ways, or there's actually 3. I've left premature birth off this slide, but there's 2 main ways that prenatal impacts lung function on birth. So anything that decreases airway growth will result in low lung function at birth, but anything that decreases somatic growth also decreases lung function at birth, and the small babies have small lungs. There are direct data in humans on almost all of these factors that's come through academic research. So ambient air pollution, decreasing both airway growth and baby size. Household chemicals, particularly in non-allergic individuals. There are genetic predispositions that impact on this. Maternal smoking has a major impact on maternal nutrition. There's much less data on maternal alcohol use. In fact, most of the data comes from animal models, and the human data is not very strong yet. And why this matters is if you follow the green line, which is normal growth, you reach your peak lung function in early adult life, and then you have a normal decline in lung function with age. if you don't reach your normal expected lung growth, but you have the normal decline, as you become older, you will develop respiratory disease. And then there are environmental impacts which can impact on this and make this all worse. Now, one of the ways that you can look at the academic research can look at understanding the risk factors is by directly measuring lung function. And we measured these lung functions. The techniques, the technical details of the techniques don't actually matter, but these are ways of measuring lung function in infants during normal tidal breathing. And this cohort study conducted in South Africa, we were able to show that if we measured lung function in infants at about 4 to 6 weeks of age before they'd had any respiratory disease, we were able to predict with reasonably high degrees of accuracy which children were going to have lower respiratory illnesses, which ones were going to have recurrent lower respiratory illnesses, which one were going to require hospitalisation, pneumonia, and which ones were going to have wheezing illnesses. So by then tracking back the exposures that impact on lung function growth, you can then build up a picture of what the risk factors are. And one of the ones that we were able to show in this study, again, the impact of maternal smoking during pregnancy. And you don't have to understand physiology to know that this line's good, this line on the right-hand side is not so good. And these infants who had mothers who smoked had stiffer lungs at birth, and this translated into an increased risk of lower respiratory illness and pneumonia. I also want to say something about the climate interactions, because I think these are where we have to make more effort. So the impact of climate change, it's a complex interaction, starting off with air pollution, burning fossil fuels, greenhouse gases that result in climate change. These have direct effects. The air pollution have direct effects on biodiversity loss and ecosystem dysfunction, direct effect on impaired human health. The climate change also increasing biodiversity loss, adverse social impact, and again impairing human health, both respiratory and non-respiratory. You can look from factors such as higher ambient temperature, altered patterns of precipitation, rising CO2, rising sea level rise, and ocean warming through pathways. So if you just look at higher ambient temperature causing heat waves, increased temperature variability, changes in surface level ozone, changes in pollen, plant growth and pollen production, having adverse health outcomes. And you can track through all of these. One of the areas which is particularly important in my part of the world is the ocean warming and sea level rise. And we are already seeing climate refugees from people having to move away from their small Pacific islands because the sea level rise is making them uninhabitable. It's a factor our government doesn't want to hear about, and it's an area that advocacy is very important. We've heard that air pollution, air quality is going to get worse, but these graphs are predicting or model changes up until the late 21st century show that the changes are not going to be evenly distributed across the world. So if you're talking about PM 2.5, mainly in the northern hemisphere, but also down in the southern, where down towards the Antarctica, and this is where it has direct impact on sea level. But ozone changes are going to be more in the northern hemisphere. Specific humidity is going to be more over the equatorial areas. And nitrogen dioxide and oxides of nitrogen are in the larger population areas. So what are the climate impacts on lower respiratory illness and asthma and pneumonia? We are going to see a change in the pattern of acute respiratory illnesses. This is already occurring, but this is partly related to the change in pattern of respiratory infections due to rainfall changes. We're going to see greater exposure to pollens, which have a potential impact on allergic sensitization with longer and more severe pollen seasons. This has an impact in a couple of ways. Firstly, pollens such as ragweed are growing in areas where they didn't before, and with olive trees producing more pollen, olive allergy is becoming much more common in parts of the world where it wasn't common before. Increased surface level ozone as a direct effect of climate changes, alter lung growth, increased exacerbations in the emergency department. Visits, we heard something about that earlier in the day, and increased emergency department presentations, particularly the bushfire smoke, which is a problem in my part of the world. But it isn't all gloom and doom. There were good data from the US and Southern California in the pre-Trump era, where regulation was able to decrease the pollution. And on this graph, there are graphs of nitrogen dioxide, ozone, PM10, PM2.5 in different districts of California, decreasing across time. And when that translates into a decrease in respiratory disease of the children in the area, on this slide, I've shown bronchitic symptoms in both children with asthma and without asthma, showing reduction in symptoms as the air quality improves. I was part of the Lancet Commission for Pollution and Health, and part of that report showed that it is far cheaper to clean up the air, to mitigate against air pollution, than it is to continue paying the costs. And I think that's a message that we have to continue to get across. I thank you for your attention. And I know we're not taking questions, but if anyone wants to contact me, that's fine too.
For your very nice presentation. For our next speaker, there's always, we think that if all this information that we generate through academia or through research is explained to our governments, and for that, I always have in mind that sometimes is the way we communicate this information to the governments. And for that, we have the Professor Dr. Barbara Hoffman, who was the past chair of the ERS Environment and Health Committee, and she's based in Düsseldorf. And she will now explain us what is the role of the professional and scientific societies and what is the translation of all this evidence and communication to our governments. Thank you so much, Barbara. Wait a second, I think we cannot hear you. Is your mic open?
Okay, can you hear me now?
Brilliant.
Yes?
Thank you.
Okay. Well, thank you very much for the invitation and for giving me the opportunity to talk here. I think I was invited to give this talk here in my function as the past chair of the Environment and Health Committee of the European Respiratory Society. And I will try to give you some idea about the activities and the experiences that we've made in these past few years. Now, to set the stage, I think you have seen this. You have seen this picture before. Catherine Tony showed it, and don't be afraid. I'm not going to reiterate what has been said this afternoon already. I just want to state the obvious, and that is air pollution causes multiple serious health effects, and the relevance or the burden of disease from air pollution is grave. And we've heard several of the prior speakers have very convincingly calculated and shown how severe air pollution acts. So this is just stating the obvious. Now, the WHO air quality guidelines that were just very recently published a few weeks ago, they very nicely synthesize the evidence of what we already know about air pollution. And they conclude that there is a marked increase in the quality and quantity of evidence compared to 2005, when the prior air quality guidelines were released. Most of the most updated air quality guideline levels now are substantially lower than they were 15 years ago. These guidelines provide robust public health recommendations, and they're meant to inform decision-making. So this is on the table. The question is, how do professional, medical, and scientific societies, how can they act? Now, the first thing is, what is our aim? And I think the overarching aim of what we're doing is we want to contribute to better health around the globe, in our region, in our country, locally, and we want to contribute to prevention of air pollution related disease. And the specific aims, how we do this is, in these, the members of these professional societies, these are the experts who actually produce the evidence. So it is important that we go out and communicate and translate the evidence to policymakers and the public, so they know about it. A second specific aim that is important is we need to inoculate the public, our colleagues, our professional colleagues, but also the decision makers, policymakers, against the actions of the so-called merchants of doubt, who try to convince us that the actions of air pollution are just fake news, like they have done in former times when they tried to convince us that environmental tobacco smoke is harmless, or when during the last 40 or 50 years, they very convincingly spread the news that climate change was not man-made. So these merchants of doubt, they are also around in the air pollution realm, and we really need to educate the public, professionals, and policymakers. We really need to inoculate them against these fake news that are being spread by the merchants of doubt. So what are the specific actions that we can do as members of medical and scientific societies? What are our strengths, and who can we reach? I have a long list here of specific actions, which I will go through in a minute. I just want to divide them into, we need to act within the society, with our own peers, and we also need to reach out. And I have some examples for each of these points now to show you, to illustrate what I mean. So the first, one of the first actions I think we need to do is we need to inform and educate our own members on the newest evidence. And every society, I think, has its own avenues how to do this. The ERS has various, ways to publish its own statements. It conducts webinars, either at its regular annual conference, or it also conducts additional webinars that are meant to pass on the newest evidence. Or another option is to use outlets like society journals or society websites for making statements. And here I'll just give you a few examples of what ERS is doing. Now, a second approach within a medical and scientific society is to develop guidelines for clinical management, because, the healthcare professionals, they are the ones who sit in front of the patient and who need to give some very concrete advice. And unfortunately, that is not very far developed yet. And this is definitely an area we need to work on. I brought you one example from the American Heart Association. they have recently published a statement that is meant as a guidance to reduce the cardiovascular burden of ambient air pollutants, and they specifically address cardiologic healthcare professionals to aid them or guide them in advising patients. So this is certainly one role that lies within the medical and scientific societies to formulate these guidelines. Now then, another area of action within the society is to engage and enable advocacy. And for that, every society that really wants to be active here needs to build some structures and networks and establish processes how to do this. Once again, as an example, what are we doing in the European Respiratory Society? This society has a specific so-called advocacy council that encompasses committees on various specific topics. Because it's a respiratory society, of course, it has a committee specifically on tobacco control, and also one on air pollution or environmental health. And these committees and the advocacy council, where they are combined, they have a very good structure. They have support from full-time people, so they can actually get some work done, other than professionals that healthcare professionals who do their clinical work and do not have enough time to engage in advocacy activities. Here, the society is actually providing a structure and personnel and networks and processes for healthcare workers and scientists to engage in and to be most productive. Okay, so these were activities that are important within the society, but we also need to reach out. And one way to reach out is to participate in authoritative reviews of the evidence, and then to provide this expert knowledge to regulators and policymakers. And two examples here are, of course, the WHO air quality guidelines, where several members of medical and scientific societies were actively engaged in the development of the guidelines or in the review and in the distribution of the guidelines. So that is one important area where we can actually use our expert knowledge to synthesize it and to communicate it to the policymakers. Another example here is holding webinars or publishing statements. The example here is a very recent webinar that the European Respiratory Society conducted together with the so-called Health Effects Institute of Boston. And in this webinar, where we specifically also addressed policymakers and regulators around Europe and the US, we communicated the new results of a set of studies that was done in Europe on specifically on the effects of air pollution at low concentration levels. Now then, a final group of activities here that I call advocate for clean air policies on the regulatory and political level. This is, of course, one of the major activities that we're doing in the Advocacy Council and Environment and Health Committee. We actually go out, meet with the policymakers and explain to them why clean air policies are important and how they can be most efficiently be designed. We also reach out to other multipliers so they can do the same pretty much, and try to enable them to do the same. And this means other societies, patient organizations, NGOs, media, and so on. And we also provide this expert information then to these other multipliers. And one example here, very recently, in this September, when the air quality guidelines were released, we assembled a group of more than 140 professional societies who joined us in writing a statement on public health consequences and of the new WHO air quality guidelines. And this was very effectively communicated across these more than 140 worldwide societies. Another example here, we also want to inform the public and other multipliers, and with publications that are designed to address the general public, that are not in expert language, but in lay language. And specifically here in this case, we made a fact sheet specifically on myths of that are being spread by merchants of doubt, who try to convince people that air pollution at the current levels in Europe are not dangerous anymore. So this is the list once again, and I just want to quickly give you one current example where we are very active and where there's lots of room for engagement by other stakeholders and professional societies. So the example is the Ambient Air Quality Directive. This is the major legislation for regulating clean air policies in Europe. And this will be revised next year. And this is going to be the first revision of this major piece of legislation since 2008. And you have seen in the prior talks that there's been a huge amount of evidence accumulating since then. So it's more than high time to actually revise this Ambient Air Quality Directive for Europe. Because these revisions are not done on a regular basis, but only with large time spans in between, this revision of the EU Ambient Air Quality Directive will most likely determine European air quality regulation for the next decades. So it is of utmost importance that this directive is going to mirror the huge evidence that has accumulated, and is also addressing the huge disease burden that is being caused by air pollution. Now, the philosophy of this European Ambient Air Quality Directive is that it is meant to protect even the most susceptible, and these are, of course, the babies and old people that suffer most from air pollution. The scientific evidence, which is the basis of regulation, that's supplied by the recently published Ambient Air Quality Directive. And currently we are in a phase of intense stakeholder involvement. And there is ample opportunity as professional society to engage here and voice the needs of the population, of the patients, for clean air, for health protection. This intensive process of stakeholder involvement will go on until next year. We expect that the first draft of the new Ambient Air Quality Directive will be presented in the fall of 2022, when after that political negotiations start, which of course involve very strong lobby groups from the fossil-based industry. So the healthcare sector, the professional organizations, they really have to get their act together and voice their needs. Here is an example of the ongoing public consultation that has just started, and where all stakeholders can write what their suggestions for the new Ambient Air Quality Directive is. Okay, with this, I stop and I thank you for your attention.
Thank you very much, Professor Barbara Hoffman, for your brilliant presentation. Hope we can beat the lobbies about our new policy in air quality. The last of the presentations for today's conference is the one that is very weighted, is from the WHO Director of Public Health and Environment Department, Maria Neira, who will explain us who will be the new air quality standards and respiratory health, and how do they impact all of us in the industries, and what is happening in Glasgow. Thank you, Professor Neira.
Thank you. Thank you very much. Good afternoon to everyone, and thanks for the invitation. I just arrived from Glasgow, so I suppose I can still share my very fresh impression of what has been discussed in there. And let me start by putting some optimism here. My feeling is that for the first time, the health is gaining a real traction and moving into the right direction, at least for people making the connection between climate change and health. And the strong connection is coming exactly because of the air pollution, because of that most of the causes of the global warming are very much related to the same causes of air pollution, means the combustion of fossil fuels. And one of the most urgent decisions that needs to be taken in Glasgow will depend very much on the fact that how much we will be able to pass that message that unless we reduce emissions, we'll not be able to reduce the 7 million premature deaths that are occurring every year due to exposure to the toxic air we are breathing. And of course, that air pollution is very much related as well to pneumonia for children exposed to the household air pollution, which is polluted. Two very important issues that for which we were very much present in Glasgow as the health community. By the way, WHO was there for the first time with a health pavilion. So we were able to organize more than 70 events related to health and climate change. And again, for us, and air pollution, because for us it's the same agenda. And we're very happy to see many associations working on clean air, working on many associations on the air we breathe, the right to clean air, the air we breathe, the International Respiratory Diseases Association. So it's this very grouping together and creating a very strong movement. Plus, we saw as well Moms for Clean Air, which is very stimulating to see these groups of moms and warriors of clean air and others, which are very much conscious about the fact that clean air is representing a problem for their health or their children, and therefore that represent a very strong reason to fight for it. Several things happening in Glasgow for the health community. One, we presented the health argument for more climate action. I will invite all of you to please have a look. There are very pragmatic prescriptions. There are 10 recommendations, very pragmatic, with a very positive language, because we are saying not only climate change is affecting our health, that we know, and is really very dramatic, and we need to adapt and we need to do something about it. But if you tackle the causes of climate change, let me tell you what are the fantastic health gains that you can obtain if you do so. And most of those health gains will come from the fact that if you reduce the causes of climate change, one of the immediate benefits will be the reduction of air pollution, and therefore the reduction of all of those diseases associated to air pollution, and of course, pneumonia. One of the difficulties, a special difficulty on the case of air pollution and pneumonia, is that where the children are exposed to air pollution is at the household level. And the reasons why they are exposed to air pollution at the household level is because their moms or their families are using very polluted fuels for cooking, heating, or lighting. And in making sure that we accelerate this access to clean sources of energy at the household level is a gigantic, is an incredible effort that needs to be done, because at the moment there are more than 4 million premature deaths associated with the fact that the families are cooking using fuels like if we were in the Stone Age. How we accelerate that transition to clean fuels sometimes needs to pass through an intermediate solution, which are the LPG, the gas, which from a health point of view could be the transition needed in order to accelerate access, but of course is always part of those fossil fuels that we want to eliminate. At least we want to eliminate those that need combustion and they are contaminating the air we breathe. And then we need to be very attentive for resolving this critical issue of access to clean fuels at the household level. Many youth movements, many commitments, things are changing a little bit because the youth are putting a lot of pressure on the decision makers. And because probably as well, because the health argument is very much now on the table. And I think this can be the final motivator to accelerate a little bit the agenda, increase vision and increase the speed at which we need to react. WHO, as you well know, issued the new air quality guidelines a few weeks ago. We wanted to do it before COP for making sure that people and policymakers will not have any excuses. And the good thing is that, of course, yes, the levels recommended now are very ambitious, very low, even more restrictive than what we have before. But the good news is that if the world will be able to reach those levels, we could save 80% of the deaths that we are having at the moment. So it means that we could avoid almost 6 million deaths every year. I think this is a very good cause, a very good objective, and the one that will allow no excuses for taking action needed on reducing those the use of those fossil fuels and the subsidies we are paying to the fossil fuels at the moment. Those benefits that can be obtained are the motivation. Once the most important ones are coming from this reduction in air pollution, then others will come from the food systems that are more sustainable, and therefore we can have healthier diets. And the third one will come from a transformation that we need in our cities in terms of mobility, traffic, and transport. That could be an enormous effort as well. So let me tell you, finishing by telling you that our lungs are very much present now in all of those discussions. I have the opportunity to discuss with who will be the president of the next COP in Egypt. And I have proposed that instead of having a globe as we normally have, a planet, we should have a planet and next to them a couple of lungs to make sure that people visualize the connection, the importance. So not only the globe and the lungs. Of course, air pollution will affect more than our lungs, but at least this is the entry door, the one that can visualize. So help me on pushing for that. The implementation of the air quality guidelines, of course, it will be difficult, it will be challenging, but it makes a lot of sense, and there are no safe levels for air pollution, so we need to move into that direction. And this transformation that is needed and the transition to a clean energy, renewable energy, healthy urban environments, and healthier food systems is a transformation that needs to be driven by us. And of course, together with the transformation of convincing people that keeping using the ecosystems as a waste bin is not a good idea, and it is certainly not beneficial for our health and will affect all of us. I will stop here. I hope I was not too long, and happy to answer any question if you want. Over. Thank you.
Thank you very much, Maria, for your presentation, for your effort, for your commitment, and for all you're doing in the name of all of the scientific persons that you're doing that in Glasgow. Thank you so much. We will now pass through the next speaker, which is Mr. Sergio Rodriguez. He's the General Director of Pfizer in Spain. He will give a few words about what Pfizer is doing with the vaccines.
Hello, good afternoon, everyone. Every November 12th, World Day Against Pneumonia is commemorated. A disease caused by infection in the lungs and normally caused by microorganisms such as bacteria, viruses, and fungi. Pneumonia can be serious, but preventable in some cases. And according to the latest data available from the National Institute of Statistics, in 2018, it caused more than 120,000 hospital admissions and more than 10,000 people died in our country. In addition, pneumonia constitutes one of the first causes of death in the first origin of sepsis. Although pneumonia is a disease with a high incidence and is known to society, the risk of contracting it is ignored. For this reason, we believe that it is essential, especially in the context in which we find ourselves right now, to sensitize and educate the population about this disease that can have serious consequences for those who suffer from it. In addition, with adequate prevention, the possibility of bacterial co-infections that would increase the burden of our health system could be avoided. On November 12th, coinciding with the World Pneumonia Day, the Global Pneumolite campaign is launched, a project promoted by the Dr. Katia Silonis, a researcher at the Hospital Clinic de Barcelona, with the collaboration of Pfizer and the support of Every Breath Counts Coalition. The campaign begins with a conference with world experts in the field that will address the importance of air pollution in pneumonia. Because the importance of this campaign lies in the need of a good approach to pneumonia, begin from the quality of air prevention through vaccines and treatment. Having an early diagnosis, effective treatments, and specific vaccination programs to prevent its appearance is essential to avoid serious complication in the disease or deaths. At Pfizer, we are committed to improving people's quality of life, and therefore it is very important for us to raise awareness about the seriousness of this pathology in the population, as well as to make known that existing measures are for its prevention and its appropriate therapeutic approach with innovative drugs. Our commitment to research and development focus on both treating and preventing infections caused by difficulty to treat resistant pathogens. We continue to evaluate opportunities and partnerships to expand our line of research and development to ensure we address the evolving medical needs of individuals and physicians in this important area of infectious disease. We have a strong vaccines R&D program, one of the largest in the industry, and focus on developing vaccines to help protect against serious threats to public health. Pfizer also believes that effective stewardship of antibiotics includes responsible manufacturing practices. Pfizer is committed to ensuring that the manufacture, use, and disposal of our products, including antibiotics, do not adversely affect human health or the environment. We are also committed to developing and implementing our climate action strategy based on science, as we help address the threat of climate change. Since 2000, Pfizer has taken significant voluntary steps to reduce our greenhouse gas emissions and optimize other aspects of our environmental performance. We are committed to setting GHG emissions reduction targets to stabilize global temperature, in line with recommendation of the Intergovernmental Panel of Climate Change. Thanks very much.
Thank you very much to Mr. Rodriguez from Pfizer in Spain. Now we are closing near to close this event, and we will present you what we call the Pneumolite videos. We will show you this media that have been created especially for this global conference. We will put you in these videos, and after that we will close the event.
Pneumonia is the world's biggest infectious killer of adults and children. claiming the lives of 2.5 million, including 672,000 children in 2019. Every country is affected. 3/4 of all pneumonia deaths occur in 20 countries spread across Asia, Africa, the Americas, and Europe. Adult pneumonia deaths are concentrated in Europe, Asia, and the Americas. Child pneumonia deaths are concentrated in Africa and Asia. 5 countries account for half of all pneumonia deaths in children under 5: Nigeria, India, Pakistan, Ethiopia, and Niger. Stop pneumonia. Save lives. For a better world, a new world. Pneumolite.
Thank you very much, and we'll see in this. We close this event, and thank you very much for all the audience, and thank you very much for the invitation, and see you next year on the World Pneumonia Day.